Lady Hardinge Medical College, New Delhi, and Faculty Orthopaedics, Orthopaedics Department, University of Delhi. A leading expert in spine surgery who will introduce us to the basic principles, instruments, and settings for UVE spine surgery.
Good morning, chairpersons and my esteemed colleagues. First of all, I thank Dr. Rahul and Dr. Abhishek for giving me this opportunity. My talk is on basic principles, instruments, and setting for UV spinal surgery. So, I have no conflict of interest to disclose. Next. So, the learning objectives of this talk is principles, instruments, surgical steps, then challenges and complication avoidance. Next. Why there is so much interest in endoscopic procedures in spine surgery specifically in recent years? Next. So there are few specific benefits for which it is being sought after nowadays. For the patient, it is less pain due to smaller incisions. So it leads to lesser use of painkillers, NSAIDs, and opioids. Then there is early return to normal activity because there is very less trauma to the paraspinal muscles and the other structures. For the surgeon, it's magnified view, so we are able to do a better job. There is definitely very less blood loss. Next. So the past is the mother of future. Improvement in technology in endoscopes, cameras, light source, along with coagulation devices had helped to improve surgical intervention with minimal interventions a lot. Next. The surgical procedures for spine disease have developed significantly over the last century. Procedures with no or minimal handling of normal tissues provides better functional results. It has been proved again and again. Endoscopic procedures do help to achieve these goals. So this is one of the basic concept I want to highlight. In endoscopic procedures, our viewing, what we are seeing is our source view is just near to the tissues which we are operating upon. In microscopic or in open surgeries, the microscope where we are looking is at a distance. So the magnification is there in microscope also, but the view is funnel shape. So deeper into the tissues, we are not able to look into that extent. But it is reverse funnel shape in endoscopic views because we put the tube inside to the cavity and with angulations, with angled scopes or say 30-degree or even 70-degree scopes, we can look far beyond our actual incision site. Next. So a little bit of history. Myeloscopes were discovered long back. Then there were spinoscopes, but major developments occurred after rod lenses for endoscopies and cold light sources. Next. Then Cambians had given us that Cambian's triangle with 30-degree endoscopes. Next. So this is MIS surgery. means we are dissecting less and less. So microendoscopy, if we can see, it takes around 1.5 centimeter incision. We put some retractor and view through that. Then there is biportal endoscopy, where 2 incisions are there, but they are far, far lesser of size, and we can go deep. Full endoscopy is, we are doing everything from single port only. Next. So the spine endoscopy, dry system is Destendo. It was started by Dr. Destendo, and then it doesn't use any fluid media. So view is there, but it is not that great with, that is, we are able to see through the fluid medias. Then there is uniportal, it is interlaminar as well as transforaminal, and now today's focus is on a biportal endoscopy. Next. So on the left side, there is uniportal endoscopy. On right side, there is biportal endoscopy. Next. Next. So this is very important to understand. Water dynamics in UBA. UBA is a fluid medium surgery, but there is actually no space. We have to create the space for the fluid. So we are developing a cavity where we can put fluid, and through that fluid we are able to see. So we lift the paraspinal muscles. So continuous saline output is critical for maintaining hydrostatic pressure. Maintaining stable water dynamics is the first step in UV. It is needed for the working space where we are working and to achieve the hemostasis. Next. So it's around 30 mm of mercury. So how we achieve that? It is roughly around a meter height from the patient's table or our head's table, operating table. So it roughly transmits to that, but there are many confounding factors. If patients is, say, with BMI of more than 35 or say 40, it would be require more. Similarly, if patient's normal blood pressure is higher, then we would be requiring more. Next. Next, please. So there is few terms there, Bernoulli's and Pascal's principle. So these are important to understand for the physics. But as such, what is the, if it is a closed space, if we are applying pressure on one side, it will transmit to the whole of the container. Next. So here we can understand that we have to create the space. Gravity is pushing fluid down. Pressure gradient created inside the paraspinal muscles and bony ligament structures provides the space and thus the clear vision of field. If bleeding increases, then we have to definitely increase the pressure, that is by the cuffs. In arthroscopic systems also we use the same cuffs, so we can increase the pressure. Next. So managing the fluid pressure is the key to successful UEB surgery. If there will be lesser pressure, it will lead to increased bleeding, so the vision will not be clear. So further there will be chances of cord rebounds. Overpressure leads to muscle edema, and if it is for prolonged time, thecal sac compression, and it can even lead to raised ICT. Next. So now coming to the instruments, it's basically, we should have all these ornamentarians to start with. So endoscopic console consisting of a TV screen, light source, then radio frequency unit we require for achieving hemostasis, then shaver system to shave off, to detach soft tissue, as well as for bony work we can use it, and then the high-speed burr which is required for laminotomies, then the irrigation pump. Next. So here we are using different types of endoscopes. It is straight endoscopes, definitely, 0 degree, but nowadays people are preferring 30 degree as well, because our field of vision is more with 30 degree. We can look beyond our incision site with 30 degree. So it We are using with it a cannula with working sleeve, which have 2 channels, one for inflow of the fluid, other is for outflow, along with trocar. Next. Then the fuse spine surgical instruments. Most of the instruments we use here in this surgery is general spine instruments, except few like dilators. So on the right side is the muscle detacher. We oftenly use it to detach the muscles in the first few steps. Then sequential dilators when we are making the ports. The others are simple other instruments we are using. It's pituitary rongers, normal rongers, nerve hook, nerve root retractors, Penfield elevators, Carrison rongers. Next. So these all are we are using. Next. So here we are using almost all the normal spinal instruments. Next. So we require a good quality camera. So nowadays 4K cameras are available. So light source is usually xenon, which give us a good view. Next. These instruments, if we have, they make our life very easy specifically for the bony work. Otherwise, with rongers, it becomes a long procedure, tedious job. So if we have burrs and the shaver system here, if we can see, is usually we are using is fluted tips, so that we are not harming, we are working on the bone and we are saving our preventing damage to the neural tissues. Then is the diamond burr. The burr used is almost always diamond because we want to cut on the side only. Next. Then radio frequency probes. There are different types of probes are available. Even most of us are using the normal arthroscopy RFs with very less voltage. Next. So OT setting, the next topic I had to cover was the OT setting. So this pictorial diagram shows the normal presentation. We take the patient on radiolucent table, prone. So the endoscopic TV screen goes in front of the surgeon. So surgeon usually doing the surgery from the left side. Right-handed surgeon, it is preferred from the right side, left side. So assistant is standing on the opposite side. Scrub assistant is on the same side of the surgeon, and the instrument trolley is on the foot end. So if CME is required, it comes from the opposite to the surgeon. Next. So this is the OT setup. So operator is standing on the left side. So TV screen comes in front of it. It is usually directly opposite. So scrub knob is on the side of the surgeon. CME is coming from the opposite side. So what we want to appreciate here is also that we want to maintain the position of the patient in little bit, so in extension at the operating side. Lumbar spine is usually lordotic. So if we maintain little bit of, if we are able to decrease the lordosis, we are able to achieve a little bit of more space so that it is easier to go inside the lumbar spine. These slides are pertaining to the lumbar spine. Next. So this is that highlighting that we want to a little bit decrease the lordosis, so hips are kept in flexion. Although I don't know whether such tables we people are using or not. What we are using is we are using a little bit thicker bolsters than the normal spine surgery, and keeps the hip and try to keep the hips in flexion, so that will decrease the lumbar lordosis. Next. So this is OT setup. Next. So now the steps. So before starting the step, we have to know the pathology. So our diagnosis should be confirmed, and there should be a good plan. If we are not planning well, then definitely surgical time will be more, and chances of muscle edema and everything increases. So well planning is half the surgery done. So after the planning, the steps starts. So what steps we are doing here is, so first we mark the level. So these steps are done under image. First we had marked the level, then obtain AP image, mark the midline and medial pedicle line. We are just going on the medial pedicle line. So this space line is marked. So proximal and distal, we have to mark 2 points on the disc space. So this should be clearly marked so that we have no problem later on triangulations. So both in AP and lateral. Next. So working and viewing portals are made in line with the medial pedicle line. So our target is spinal junction. Next. So this should be checked in lateral view, our level, verify the correct spinal level. We put guide wires on the patient initially outside so that our skin markings are correct for triangulation to look at the trajectory. Then we mark the rostral and caudal incision sites. Next. So this is after marking, we are putting the cannula inside proximally on cranial as well as caudal. After putting guide wire, we put serial dilators and check for our level as well. Next. So step 2 is creating working and viewing portals. So create the working portal by marking, it's around 5 to 8 mm incision, directed towards the disc space. We cut the fascia in line with skin incision. We put the muscle detacher to lift the muscles. Then use sequential dilators to dilate the facial opening, and then we put the tubular retractor. Next. So this is for the viewing portal. It's almost same size incision. We put the endoscope with. So if we can see here, it's at the spinolaminar junction. So and we put the endoscope with trocar and target towards that point. Then we start the fluid. Next. Then is the triangulation. Insert the whatever instrument we are using. Initially we use probe into the working portal and touch the tip of endoscope here and see this probe under the endoscope. Next. So this is triangulation. So this is proximally is on cranial side is the surgeon is on left side. So proximally is the viewing portal, and in his right hand is the working portal. So this for the starters, it is easier. As we gain experience, we can do from the right side as well, but it's little more cumbersome from the right-handed surgeons. Next. So this is the pictorial where we want to go. Initially we start with this junction. We remove little bit bone if required. Then superior articular process. That is usually hindering our view. So medial 1/3 of it is easily can be removed without any instability. Then if required, undersurface of spinous process, and if required, distal lamina also. So that is very important. Can we play the videos? Yeah, so that video is next. So these steps will be repeatedly again and again by all the speakers, but just I will go through the steps. Then we do the laminotomy, and with bone cutting shaver or high speed burr. So we remove whatever space we require. Can we play the video? Then we detach the yellow ligament. Yes, this is laminotomy. So the yellow ligament or ligament flavum is going upwards. It's on under surface. So we have to remove a little bit of bone here. And if space is less, we may have to remove more and more bone. Then expose the ligament. Play this. So here we are able to find out it. Then we detach it, so that we can visualize the desired dural structures. So these curates, angled curates, are very helpful for detaching the ligament or any soft tissue structure from the bone. Next. Next step is entering the epidural space. We use Carrison rongers or even with curate itself. Play this video, please. So we are retracting little bit and removing bit by bit. 90-degree ronger. So the view is very clear with biportal endoscopy. So we may use the cautery. So it should be under vision or direct vision. Next, so we retract the neural structures towards side. So here, this is epidural fat, and below that we are able to appreciate the nerve root. Next slide. So then we have to identify the lateral margin, and so here is the nerve root, and this is the protruded disc. Next slide. So have to identify the lateral margin if we when we want to go inside. Next slide. So we dissect and mobilize the nerve root, retract the nerve root, perform the annulotomy, and then deliver the disc fragments on the protruded disc. Play the video, please. Bit by bit. So we have to be patient here. Initially, first, because as the disc is protruding, so the nerve root is under stress. So it is tensed over its protruding structure. So we have to retract little bit. If we do too much retraction, it causes traction injury. So just retract a bit of pieces. When we remove, it is laxed, and then we can do further work. Next slide. Just so last slide. So then, if required, and we can palpate the annular defect and remove the remaining fragments, then wash and close. Next slide, please. We can, next slide. So there are few challenges. The initial challenges is viewing only, the triangulation. So we have to have pre-planned it very well. That is the main problem. Other is the bleeding. So that is, we have to check our fluids again and again. And third is, if the surgery time we have to see, if the surgery is prolonging, it will cause a lot of problems, muscle edema as well as raised intracranial pressure can be there. Next slides. So the planning is very important. If patient is very bulky, so the ports will be a little bit far away from one another. If patient is thinner, then they will be near. So planning is very important. Next. Few further readings. Dr. Paulinji has a very good book itself. We can go through that also. Thank you for your patience.
Thank you, sir, for that illuminating talk. As our next speaker of the morning, I would like to call on the podium Dr. Mukul Kosel, consultant orthopedic surgeon with expertise in the field of minimally invasive endoscopic spine surgery, besides his added interest in arthroscopy of shoulder, knee, and sports injury. His talk will deal with UVE surgery for lumbar disc.
Left podium.
Good morning, everyone. I would like to thank the organizers, the Greater Noida Orthopedic Association, the team at Sharda University, Dr. Rahul Kaul, for giving me this opportunity to talk on this topic of UVE for lumbar disc. So briefly, we all know it's unilateral biportal endoscopy. It's a minimally invasive surgery. It's primarily a fluid medium surgery. We use two incisions. One port is for the endoscope. The other is for the working instruments. It is just like any joint arthroscopy, but here there is no joint. There is a potential space, so we need to create a working space. The surgical anatomy, the approach, and the indications, everything remains as similar as for a conventional open microsurgery. One can gradually go from discs, decompressions, and gradually to advanced procedures like listhesis or probably degenerative deformity also. But one need to understand the concepts of orientation, triangulation, and the access corridor. So the thing to understand is the fluid medium. It comes in through your endoscopic channel, and you have to maintain a constant hydrostatic pressure, because excess can also be damaging and less of it will probably obscure your vision. So the bone epidural oozing and the bone oozing usually is occurring at a epidural pressure, at a pressure of 15 to 25 millimeters of mercury, and a gravity-assisted inflow at the surgeon's head height usually maintains a 30 to 50 millimeters of mercury hydrostatic pressure, which takes care of this epidural bone oozing. So let's understand the concept of triangulation. So triangulation is nothing but to bring your tip of the working instrument in front of your endoscopic camera tip. So if it's an open triangle, means that both things are quite far away, the instrument is not going to be visible. If your triangle is going across, then also your instruments are going to fight with the scope and you're not going to see the tip of the instrument. So whenever the tip of the instrument is seen in front of your camera, that means it's a good triangulation. And the access or the approach corridor, it is an interfascicular approach where we try to go and exploit the corridor between the fascicles of the multifidus muscles. And once we land over the lamina, there is a fibrofatty tissue or a potential space where once we turn on the fluid, it lifts up the muscles, and with the help of some radiofrequency device, we clear up the lamina and the interlaminar window before starting our bone work. One thing of note whenever you're planning for a lumbar disc surgery is that as one goes from L5, S1 to higher lumbar levels, the relation of the disc space with the interlaminar window changes. As you go more cranially, the disc level also starts going up, the interlaminar window also starts going up with respect to your respective disc levels. So the surgical consequence of this is, if you are planning like an interlaminar or paramedian approach at a higher lumbar level, to reach that disc, you have to perform a more bony dissection, more laminotomy, and as the lamina is narrow at a higher lumbar level, the risk of a facet fracture or a pars fracture is high if you tend to take a paramedian approach. So other alternative approach which other speakers are going to take up are going to be probably more suitable at a higher lumbar level. The armamentarium, as already the previous speaker alluded to, you need an endoscopic camera. It could be a 0 degree or a 30 degree, whichever way you're comfortable with, a burr system, an RF system to control the coagulation and the bleeding issues. Irrigation system, it can be gravity-assisted or a pump-assisted, but I prefer a gravity-assisted inflow. Nerve root retractor, angled pen fields, Kerrisons, everything which you have in your routine general spine instrument set. The other things which are a bit unique in this UBE is basically these UBE portal retractors, scope retractors, which are unique to the UBE system. These serial dilators, these nerve root retractors, these osteotomes, pen fields, and hook probes, they are routine in arthroscopic surgeries or in other spine surgery. So the OR setting, the surgeon, I usually tend to approach from the more symptomatic side. The assistant stands opposite to me. They hold the UB retractor to control the water flow, and the scrub nurse also stands on the same side as the surgeon. The patient is usually put prone on neutral lordosis, and the CM is preferable that it is can be maneuvered in both AP and lateral views. Now there are many ways to approach this pathology. It can be a ipsilateral approach where you are standing on the same side of the pathology, whether the pathology is on the left side or on the right side. You can stand on the left side, but you can approach or dock your instruments on the right side for a right-sided disc. You can go contralateral sublaminar, or you can take a foraminal or a paraspinal approach. So I'll be sticking to the paramedian axis in this talk. The paramedian approach, it is quite suited for central and lateral recess pathology. And usually for that, in an AP view, you mark your midline, you mark your medial pedicular line, you mark the upper end plate of your target disc, and usually the base of the spinal laminar junction is your landing zone or the target area, and about 1.5 centimeter above and below on the medial pedicular line, you mark your portals, which gives them almost a 2.5 to 3 centimeters distance between the two portals. And all your instruments from this incision, they are directed towards the target point, that is the base of the spinal laminar junction. So this is a series of CM images taken where you mark it on the skin, and once you nick your fascia, all your instruments are directed towards that spinal laminar junction. And once you have achieved your triangulation with the help of the CM and the tactile field, you put in your scope, you put in your UB retractor, turn on the fluid, and start the surgery. So this is a small video of a left-sided paramedian approach for a lumbar disc. The 9 o'clock is the cranial end, 6 o'clock is the facet end. So you expose the lamina, burn away the interlaminar soft tissues with the radiofrequency device. Use a blunt instrument to palpate the base of the spinous process or the spinolaminar junction, where you start your initial bony work. Burr is quite helpful, especially in hard quality bone, to burr away the dorsal cortex and preserve the ventral cortex, which can be taken away with the Carrison ronger. And you perform the laminotomy till you detach the cranial attachment of the flavum on the upper lamina. Once that is done, I usually tend to put in a patty, just like an open surgery between the flavum and the dura, to create another, probably some space for my Carrisons to go in and take that bite of the flavum over my dura. Once I expose the shoulder of the traversing root, here you can appreciate that the disc is how it is just tenting and pushing the root, and the root is pink and inflamed. Now with the radiofrequency device, you can just control the bleeders before you perform an annulotomy with a blunt instrument or a blunt knife. I tend to basically use a blunt end of the Penfield to make an initial annulotomy puncture, and after that a small 45-degree 2 mm Carrison to open up this annulotomy, and the disc starts coming out. And with a series of disc punches, disc forceps, you can remove the disc till you are satisfied that you have decompressed the root quite adequately. Annuloplasty can be performed with the radiofrequency device. And once that is done, you can just see the amount of decompression of the traversing root. And sometimes, especially if the patient is on blood thinners or if there's a lot of bleeding, I tend to put in a drain also in such cases. And similarly, if this is a right-sided approach, I'm standing on the right side, approaching from the right side, young guy, L4-5 disc level, even though it's a central disc, but he's very symptomatic on the right side with minimal left-side complaints. So this was the skin marking. In this case, we probably went from the right side, yes. And once you make your portals, you want to serially dilate the working portal. In the right hand, when you're approaching from the right side, your working instruments go cranially and your working portal goes caudally. So your working portal is going to be having a lot of serial dilation to ensure ease of access of passage of instruments. And once that is done, just with your arthroscopic sheath, you can just railroad it over your switching stick or the Wissinger rod. Connect your camera. And once you turn on the fluid, you have to ensure that there is a continuous outflow of the fluid. And now here, the orientation changes. The cranial lamina is now at 3 o'clock, the facet is at 6 o'clock, caudally is at 9 o'clock. And here I'm performing the cranial laminotomy with the help of a Carrison punch. The burr is also quite useful if you're not able to get a good bite with your Carrison punch. And then you detach it till you are able to detach the flavum cranially. And then you start working laterally towards the facet till you release the flavum and are able to see the shoulder of your traversing root. The good thing about these saline endoscopy is that you get a very clear distinction between the ligamentum flavum, which is quite pale in appearance as compared to the glistening, shiny feel of the epidural fat. And once here we can appreciate that the traversing root is now being exposed as it goes into the recess and into the foramen. The radiofrequency device is quite helpful to control the epidural bleeders here, just above the disc space. So that's the disc below. And once your root is quite free and mobile, after opening up the recess, that is a time when one would like to place some kind of a retractor to gently mobilize and retract the traversing root to expose the disc. Now this is placement of a UB retractor, exposing of the this protruded disc, and again annulotomy, removal of the disc fragments. One thing which I tend to do is once I've convinced that I've done a good discectomy, I put in a suction and push saline in to see the resistance which I'm getting. If I'm getting a lot of resistance, I'll probably remove some more disc. And once that is done, this is the extent of decompression. The amount of disc removed, the shoulder and the axilla should be clearly exposed and visible. So the differences between a left side standing and a right standing approach is, when you're, for a right-handed surgeon, it is quite easy operating from the left side. The reason being because the scoping is being held in your non-dominant hand and your working instruments are in your dominant hand. The burr tip, the issue is when you're using a burr standing on the left side, the burr is almost, if it deflects, it's going to hit your scope and damage your scope. So you have to be very careful of that. And while standing on the left side, it is easier to work cranially. And if you're a right-handed surgeon and you are doing a right side standing approach, your portals are going to change. Your working portal is going to come down from the down in your left hand, and your working instruments are going to come from the cranially. And whenever you're using a burr with a guard, you are unable to see the burr tip clearly when you're doing a cranial laminotomy. And sometimes, because if you're using a 30-degree vision scope, sometimes it can be quite disorienting initially, because the lamina is going to appear quite awkward if you're standing on the right side. But for a right side standing approach, it is quite easy to work caudally. Another approach which I want to allude to is a right side docking for a right-sided pathology while the surgeon is standing on the left side. So in this, again, you mark your target disc, the midline, the medial pedicular line, and you standing on the left side, you dock, you make your portals on the right side and dock on the right side facet or the interlaminar area. And with this, the 12 o'clock becomes the facet, the 6 o'clock becomes the dura and the midline. As you're standing on the left side and docking on the right side, the 9 o'clock is going to be the cranial end, 3 o'clock is going to be the caudal end. And this is how it looks like after doing an initial laminotomy and exposing the flavum. And once you have removed more of the lamina, you can see that the flavum is quite nicely apparent now. Then you detach the flavum cranially. And once you deroof the flavum over the traversing root, you can see the traversing root going in like this. You retract it with the UB retractor and expose the disc, perform a discectomy, and once the discectomy is done, the root is now relaxed and fall back into its place. Complications can happen just like any conventional surgery. There can be epidural hematomas, there can be dural tears. Infection can also occur. If you've done facet cyst formations can occur. There can be recurrence of stenosis or the recurrence of the disc prolapse. But something which is quite unique to these UB procedures are that because you are using a radiofrequency device, there is a risk of thermal injury by a direct contact to the neural elements, or sometimes there can be low temperature cautery burns. And if you are doing a paraspinal approach and you invade into the retroperitoneum, there is a chance that you may cause a massive fluid collection. And initially, there can be visual disorientation. Sometimes bleeding may cause quite a lot of trouble, and there is a risk of damaging your scope when you are working with a burr. The differences between a monoportal and a UB are many. A tubular system, the monoportal system is basically a tubular system, and the UB is basically a subtubular system. The mobility in UB is far more as compared to a monoportal system. Sometimes, if you're going for a transforaminal approach, you have to be conversant with the new surgical anatomy, like the Cambine's triangle. And usually, the monoportal, there can be some issues if you're doing a transforaminal approach for stenosis. Fusions, you probably may have to use some kind of an expandable cage. But with the UB, all kind of a conventional instrumentation, conventional implants can be used with the UB system. So why UB? It's a familiar posterior anatomy for all of us. We are able to preserve the stability. The endoscope is inside, your eye can't get any closer. Everything moves separately. It's an unparalleled mobility. The over-the-top contralateral and foraminal decompression is under better visual control. And if you're planning for a fusion, you can put your endoscope directly into the disc space and see your end plate preparation quite nicely. The flip side is that, yes, initially you will have to invest more in your radiofrequency wands. You have to get oriented to the triangulation. And as you're working so close to your pathology, sometimes you can get disoriented also. There's always a risk of damaging your scope. So initially, it is always best to invest in a like I would say economical options for the scopes, and you need an assistant to control the manage the UV retractor, and there can be fluid related issues. So if you're about to embark on this journey of UB, it is always better to first join UB groups on social media, be curious, keep on asking questions, visit the masters who are doing UB surgery regularly, keep a bone model in your OPD or office, orient and try to triangulate on those bone models, attend as many cadaver courses as your practice allows. Initially, if you're a right-handed surgeon, try left side cases, avoid tight stenosis in early learning curve. Better to use longitudinal incisions in your initial learning curve, because if you're getting stuck, you can usually connect them and convert it to eye open or a microscope. Always check with C-arm that you're on the right level. If bleeding occurs, always your anesthetist can control your blood pressure. Keep the abdomen free before prepping and draping. I tend to use injection tranexamic acid, radiofrequency, Surgicel, bone wax, putting in cottonoids, gel foam, and flow seal. They're all valid options. If a dural tear occurs, significant dural tear occurs, it is better to convert to a dry system or any open microsurgical technique which you're comfortable with. For small tears, you can even put in some fat graft, tacosil, and place some gel foam and come out, and probably it's not going to cause any issues. With this, I would like to invite you to a course on 20th and 29th September, which we are organizing in Chandigarh. It's going to be a arthrospine and a UB live cadaveric course. So we hope to meet you there. Thank you very much for your patient listening.
Thank you, Mukul. We invite the chief guest for the next session, Dr. Shankar, Dr. Tarun, Dr. Guru, and Dr. Vikas can take the chair, please. This session is open for questions. In the meanwhile, we are setting up for Dr. Park's talk. So any questions for the speakers, please?
A very nice presentation indeed. I think for beginners, Dr. Mukul pointed out 2 or 3 very good points about the use of cottonoids or putting a drain, or especially when the patient is on blood thinner. So I would like to take his opinion about what kind of precautions do you take when a patient is on blood thinner. And by blood thinner, I mean aspirin, clopidogrel for both separately. And for how long do you normally keep the drain? Second thing which youngsters would definitely like to know is, what percentage of your instruments do you overlap between arthroscopy and the UB? Also, this question is important because youngsters, initially, they might not want to invest too much money. So these 2 questions are very pertinent whenever we are starting UB as a super specialty in spine. So I think these questions are related to all the gentlemen, everybody who's here to learn UB. So both the speakers can answer based on their experience.
So, sir, regarding the first question of the drain, if the patient is on like single aspirin, 75, 150 milligram, I don't tend to postpone the procedure. And if he's on more than this aspirin dosage, or if he's on double antiplatelets, I tend to wait for 5 to 7 days after withholding those medications. And usually, per operatively, I would say I won't do anything different. I tend to put in a drain, but the decision of putting a drain is basically if they are on antiplatelet, that is one thing. On table, if I felt that there is a lot of bleeding which I had to tackle or manage with, then I tend to put in a drain. If I'm working at a cord level, I'll always put a drain. If I'm instrumenting the spine like I'm doing a fusion, I'll always put in a drain. When to remove the drain? Usually I keep it for 48 hours. And the average amount of drain output I have noticed in my experience, it ranges anywhere from 20 to 40 mm. That is what I have found. And regarding the second question of what are
overlap
the
between the
instruments
arthroscopy.
overlap, I tend to use the same arthroscopic shaver. It's a striker shaver. It also has a burr attachment. So same thing which I use in my shoulder and knee arthroscopies, that same instrument can be used in our spine as an endoscopic, but I don't invest, or I don't recommend investing in a special, I would say, endoscopic burr.
And 30-degree scope.
And I'm orthopedic surgeons are trained in 30 degrees, so I'm more comfortable in 30 degree.
Yeah.
So 30 degree scope for me, same instrumentation, the radiofrequency probe which we use in our shoulder, subacromial decompression, that suffices in the spine also, sir. So there is no...
do you change the setting of your RF probe when you are closer to dura than when you are away?
To, it all depends upon which manufacturer probe you are using. So I'm using a Mytech system. So with the Mytech system, after trying and everything, I have realized that when I keep the coagulation and ablation on 2 and 2, whether I'm working above the lamina or whether I'm working after opening the flavum. I used to usually keep it at these settings. And if I'm working probably in the foramen where the root is quite close, then I tend to turn it down to 1 coagulation. I don't use ablation near once I've opened up the flavum anywhere near the neural elements. And sometimes if I'm doing multi-level and before I've done the laminotomy, sometimes I push the limits up to 4-4 so that I can just burn it faster above the lamina, sir.
Sir, can I ask a question? Excellent presentation, Dr. Mukul. Just 2 queries. Firstly, if I'm a beginner, if I'm trying to use UBE and I make longitudinal incisions for both the portals, there would be a tendency sometimes they might connect.
They might connect.
So what is your take on that, how to prevent a problem like that happening, because then your hydrostatic pressure is not going to work. Secondly, second similar, I mean, how do you ensure that the pressure doesn't go down or it doesn't go up? How do you assess that on table? Because this is, both the sides is going to be a problem. So,
so the first question, that the portals, how do we, I would say, ensure that the portals don't connect to each other? So the thing is, the books, they mention around 3 centimeter gap, provided they are transverse incisions. But you can keep like the edge of one and the edge of the other. Keep a 3 centimeter bridge between them. But then you have to realize that sometimes your angling may increase a lot. So sometimes when your kerison goes into the working portal, you might have some issues taking that bite of the laminotomy. So that is where the burr will help you rather, because your kerison is not going to hook under the lamina. So burr can make your job easier, but be very careful that the burr doesn't deflect and damage your scope. That is one thing about how you can take care of the scope. The other thing is you can make one longitudinal, keep the working portal, because working portal is relatively smaller. You can give it a small transverse nick and put your scope through that. That is also the other way to probably avoid connecting the incisions together. And the second question, sir.
Can I add something to it?
yeah, sure.
So whenever you are using vertical incisions, make your skin incision as vertical, but your facial incision as still horizontal. So that will not cause your portals to close once the
Yeah, it won't extend in that then.
Yeah.
That's a good suggestion.
Second question about the fluid, sir.
How to maintain the pressure?
So I don't monitor the pressure actually. But
How
the
do you
thing
assess
is,
it? How do you assess it?
thing
once
is,
the pressure starts going, you will start seeing a red screen. Bleeding will start happening.
You have to see the bleeding. If it's a lot of bleeding, you might require to raise your irrigation system. So basically on the bleeding view.
So that will stop, but how do you ensure that it doesn't go too high? I mean, that is another.
for too high, sir, you have to ensure that your output is always maintained.
Right.
It is very important. So always you have to, in between, whenever you will, with experience, you will realize whenever the pressure goes down, you will start seeing that the ooze is going to increase. At that time, you tell your assistant, change the water, pani check karo. वो तो आप पता लग जाएगा.
So regular IV stand and
the
that height should be
rising
usually-
part of it is कि if you are doing it on a regional, initially probably you will be doing it on a GA, but if you are doing it on a regional, the patient is going to start complaining of neck discomfort. Because whenever the epidural pressure starts rising, it's going to get transmitted cranially. And they'll start complaining of vague neck discomfort, and at that time, you have to be very careful. Before that, you always keep on checking your portals. पानी आ रहा है, बाहर की नहीं आ रहा है. Sometimes you will see that बड़ी अच्छी pristine clear vision हो गया, और पानी अंदर नहीं आ रहा, वो पूरा आपका field जो है सूज गया हुआ, skin सूज गया हुआ सारा का सारा, पानी बाहर नहीं आ रहा. So maintaining your outflow is very important, so that your pressure doesn't rise. Because whatever is going in, if it is coming out, it is not going to cause a rise in pressure. But if the pressure starts rising, these are the warning signs. Regional patient will start complaining of neck discomfort, he'll start moving, tossing, turning, and the moment you either control your outflow or you convert to a dry system, you'll notice that this thing disappears.
Thank you.
No panel pump, sir, nothing. Gravity assisted bus. Sir, I personally have no experience with the fluid pump. The way I was trained, I was told that it should not be used, but there are certain speakers who use it, and probably they will be able to answer this question much better.
No experience with pumps. It's the gravity assisted. Just you raise it or do it a little bit down. But pumps are definitely with experts if you know the pressures only.
Fluid pump is a good option, but it's very expensive. So it adds to the expense of your surgery. But if you have it, you can use it. 30, yeah, 30.
I have some experience with using fluid pumps initially, but the problem with fluid pump is it is not a continuous pressure, it's a pulsatile thing. So it keeps on showing all the tissues pulsatile all the time. With if you are not using a fluid pump, it is a good way of increasing and decreasing the pressure just by removing the sleeve, letting the pressure increase inside. If you do that with a fluid pressure pump, if you take out the sleeve, then the machine reduces the pressure to maintain it to the same level. So you lose that advantage where you actually want to have a bleeding control by increasing the pressure inside. You actually have to change the setting of the machine every time. If you are using a gravity aided thing, you just take out the sleeve, put your finger on top of the outflow, increase the pressure, visualize from where the bleeding is coming. So there are certain advantages of using, and that temptation that jab bhi bleeding बढ़ रहा है थोड़ा सा pressure बढ़ा दो, that is always there. So I don't want that thing to happen. One of the things that he also asked, if the patient is under GA and you see that there is an unexplained rise in the blood pressure where the anesthetist is not able to find out the cause, it is probably the same thing. Mukul told about the regional thing, but in GA also, unexplained rise of blood pressure, you stop the inflow of the irrigation and within 2-3 minutes the blood pressure comes down. The culprit is your irrigation pressure only.
Excellent presentation, sir. Dr. Kosel, Dr. Kamboj, we say very thanks. And I think the learning curve is a bit steep, but we all are here to learn, and hope we'll definitely climb it. Thank you. Thank you.
Thank you.
Rahul, are you on? It's going to take another 5 minutes.
Ajay, good morning everyone, and I am not worthy of this chair because I don't know endoscopy surgery, but because these boys are kind, they invited me, and it's good learning for me. I find so much people interested. And so how many people are doing UB till we get this on? How many? Can I have a raise of hands? And you are the experts. So Aditya is come. He is a spine surgeon from Bhubaneswar, so he is very interested. And Varun, I also seems. Varun was telling me there are some arthroscopic knee surgeons who have also come. How many of there are arthroscopic knee surgeons? So what will spine surgeons do? So what interests the arthroscopic surgeons to delve into the spine? Isn't there enough work in knee, hip, shoulder, ankle, wrist? Yes, I agree, but we were doing all this, and I remember many years ago, 15-20 years ago, my chairman said, "Ji Shankar, tumko khali spine karna hai. Tum joint replacement nahi kar sakte," because it was easy for us and quick and fast. So I had to give up arthroscopy and joint replacement and pelvis because Chala, good. It's very nice it's a nice university. This first time I've come. It's a long way, but it's very nice. When Abhishek is ready, we are ready. Guru, Vikas, Tarun.
So usually the scopes take longer time, so the talk is also going to take long time.
I think they're setting up the connection for Dr. Park. Rahul has to give
So meanwhile, I think if they have any more questions, I think Ketan and all those people can answer. So if you have any,
I've seen some videos of yours, so they are quite good and explanatory. So I think the scopists are also social media activists as well. So I find a lot of them, and Aditya tells me, sir, you can find Dr. Deshpande's Ketan's videos and others. So while coming, I saw some videos. It looks very nice, interesting, everything you can see. But I suppose the learning curve is long. How many cases would you need to a person like me who is now turning 60, how many cases would I need to go into this? When in a discectomy, I can finish it off in about half an hour's time. So how much time would you think I would need? And how long is my learning curve?
Not more than 8 to 10 cases, sir. Because the way now we have the kind of things available, just like you mentioned, online also, or even good mentors who can just teach you the basic steps. We should not be looking at UB as a different technique. It is the different way of doing the same thing that we are doing inside. So it is only the part of reaching up to the interlaminar space, the triangulation part, which is different. Everything else that you would do in open surgery. Most of the people with, who are trained with me also, they don't exactly follow what I follow. They do the same thing, where some places, some might be using a curette, some may be using a dissector, some are happy with an osteotomy, some use a kerosene ronger. So it is a personal choice, and because you have the freedom of mobility and no restriction of size of instruments, you can just increase the skin incision by 0.5 centimeter and 4 or 5 mm kerosene punches can go inside. So that gives you the flexibility, and somebody who has a good amount of experience in open surgery microscopy, it is very, very easier. Only
what I understand is the fluid pressure is a little challenging. Understanding the mechanics of fluid pressure
fluid
is
outflow is the challenging part, because we don't use pressure pumps. We only use a gravity aided system. So as long as a good fluid is coming out, you don't need to worry about increasing pressure or any other things. And the second thing is, you cannot work in a turbid fluid environment. Like in open surgery, you would have a suction tip in one hand and an instrument in the other, and you will keep on micro suctioning the part where you want to work. Here it doesn't work that way. Here it's a whirlpool which is created inside, and every small bleeder which is in some other area which is you're not directly coming in contact with your operating field also will be brought in by the irrigation fluid whirlpool around, creating sufficient pressure against gravity and then coming out. So you have to be very meticulous with the amount of soft tissue dissection that you do. Every small bleeder on the way, you should not just neglect it and just continue your way towards the surgery. So if you follow these 2-3 steps, so what I recommend right now is not to plan your UB surgery on day one. I always tell them that you go for your next 10 cases of open micro decompression surgeries. You start by taking vertical incisions 1 centimeter lateral to the midline with a gap of 2.5 to 3 centimeter in between. Try putting in the instrument. Try to get a tactile feedback of whatever bony feedback you are getting. Try to reconfirm things under CM. You take a transverse cut in the fascia, vertical cut at the level of the skin. Do this for first 6 to 7 cases. You do triangulation. Don't put the scope. Don't take the scope in the operating field. Just spend 10 to 15 minutes for the next 10 cases. The moment you start getting a good tactile feedback and reconfirming where when you shoot a CM and you had already known that this is lamina, this is laminospinal junction, this is facet, and you can confirm that within next 2 to 3 minutes, then you go for the next step. So the next 5 to 6 cases you put in the scope, you try to visualize. If you plan a UB surgery on Monday and you spend 2.5 hours doing a single level discectomy, you'll be depressed. You'll say that I would have done 2 or 3 cases in that time. So that is not the way you should progress. So if you keep on taking it step by step, triangulation, working space creation, handling the bony work, being able to use a 80,000 RPM machine and still getting a good outflow where the bone dust is filtered out, and then you plan your UB surgery after 15 to 20 cases, then you would be able to do it in the same time as you would do in an open surgery.
excellent. I think that's a very good tip. We can start then. And thanks for encouraging that we can manage it in 8 to 10 cases. Are we ready?
Sir, I'm waiting. Yeah, we are ready.
Okay.
Sir, आपको
Can you hear me?
Yes, sir.
Hello, everyone. I am Cheong Park, South Korea. It is my great honor to have an online discussion for a UB surgery. Please show me my video.
Can we play the video?
Yes, yes. Dr. Ketan?
Yes, sir.
Yeah, good to see you.
Yes, sir. Very nice to see you. How are you?
Yeah, very nice.
How's the preparations for COMIS?
Yeah, we are doing very well. Many foreign doctors
Yeah.
want to join us.
I think Rohit is there with you.
Roy in Seoul, I'm in Daejeon.
Oh, okay.
Different, but we can contact with the watch phone.
Okay.
Okay. Are you fulfilling my video?
Yes, sir. We are working on that. Just 1 minute.
Yes. Actually, it is the second time having online presentation. Making video is not easy to me. How about my voice? Is it good? Is it clear?
Yes, absolutely.
My voice.
Yes, sir.
Yeah, I'm having online with my handphone. Okay, I can see it. I can't hear any voice. Hello?
Operating from the right side can cause a mismatch between instrument and the lamina. 2/5. The calcium punch needs to be rotated 180 degrees, which can be uncomfortable. Also, there is less space for moving the instrument freely.
Rahul, वो
Making
starting
the
से play कर
procedure
सकते
hard. This slide shows the anatomical feature of upper lumbar spine.
Hello everyone. First, I would like to start by congratulating all of you on this workshop. It's a great honor to be part of such an event. I would like to express my gratitude to the organizing team, especially Professor Rahul Kaur, who is not only a brilliant organizer, but also a dear friend of mine. I'm confident that this workshop will be a valuable experience for all of us, and I am pleased to share my experience with you today.
I am the one of main edit for several textbooks on spine and scope, covering advanced technique in lumbar, cervical, thoracic, and bipolar endoscopic surgery. With the endoscope, we can access almost any part of the spine for surgery. The contralateral approach is one of the key techniques for reaching hard-to-access areas. For the right-hand surgeon, actually right-side UVE surgery is very difficult because handling a drill or calcium punch, it is very difficult on the right side. And if we have a contralateral approach, we can preserve a facet joint more effectively. Challenges of right side surgery. Operating from the right side can cause a mismatch between instrument and the lamina. 2/5. The calcium punch needs to be rotated 180 degrees, which can be uncomfortable. Also, there is less space for moving the instrument freely. Making the procedural part, this slide shows the anatomical feature of upper lumbar spine. The lamina is long and narrow, and the facet joint is oriented vertically. The interlaminar space is also narrow, which makes it easier to damage the facet joint during surgery. The contralateral approach protects the facet joint. The letter X shows the damage in the traditional approach, but the blue line shows how the contralateral approach avoids harming the joint, leading to better stability. For the contralateral approach, we can create a keyhole at the spinolaminar junction. The shape of the keyhole can be adjusted based on the location of a disc or lesion. For example, we can extend the keyhole cranially or caudally, depending on the case. For a contralateral approach, nearly all kinds of hernia discs could be treated with the contralateral approach, especially for posterolateral or foraminal disc is the best indication, but central locate or parietal locate disc is contraindication. In the case of asymmetrical spinal stenosis, such as facet joint cyst or OLF, in this case, we can approach from the less severe side using the contralateral technique, which makes the surgery easier. In the case of two-root decompression, it means F3 root or F4 root, action root or traversing root compression. With this technique, we can remove, with a single keyhole, we can decompress both root, action root and the traversing root. So we can avoid the need for two separate surgery. So okay, here is your picture. Sure. Can you check the CME and the Endoscopy together. Do that. And here the middle of the okay. And here the upper margin of pelvic. Okay, Shamon. You can make sure shoulder can do it. Here the inferior wall of pelvic. Can do it. Inferior medial wall of pelvic, inferior wall of pelvic. Okay? And the axial root. Stop. So this is my video publication for a contralateral approach with the right side downward migrated disc. So before operation, I would like to have an indocoming injection into the disc space to stain the fragment. If you stain the fragment, it's easy to find the fragment. And the most important thing is making skin incision. So location for the skin incision is very, very important. So lateral recess is the deepest area and most difficult area. So your skin incision for the working port always include the lateral recess and the splitting of muscles over the laminar bone and then we can make another skin incisions for cranially for about 2 cm apart. Left side, that is the skin incision for the endoscope, and I'm putting the tube. And the other right side, because I am a right-hand surgeon, so actually pathology is the right side herniated disc with a downward migration. But my skin incision is the left side, as you can see. So, and the dilation of skin incision, especially for fascia. Why fascia? Fascia is the main block. Fascia is blocked outflow. So maintaining outflow is the most important. So dilation of fascia. And I am trying to insert another tube. So I would like to call this surgery bitubular surgery, because we have already single tubular surgery. So tube, I like to use tube because the outflow is much more better compared to semi-tubular systems. So if you maintain good outflow, your vision is very, very wonderful, very, very clear and very wonderful.
So clean up the interlaminar space because we have to start our drilling spinolaminar junctions. So I'm making drillings, the cranial extension of keyholes on the left side, but disc is located on the right side. So I am doing the laminotomy on the left side laminar keyholes, and try to have sublaminar approach from left side to the right side. That is a contralateral approach. So you have to make a keyhole on left side lamina with the preservation of left side facet joint. This is a ligament problem, especially this is outlayer ligament problem. So we have to make a stage. So I mean drilling stage and the separation of ligament from stage. So I'm nearly complete the drilling stage. Here, you know very well, left side is cranial and the right side. 3 o'clock is your left side. And the 12 o'clock is the right side. And 6 o'clock is the left side. So I'm doing sublaminar drillings. Sublaminar drillings means I'm drilling in a part of right side lamina. And then I'm trying to separate the ligament problem from the bone. So after completing your drilling stage, you can start the separation of ligament problem from the bone stage. You can start. Yeah, you can see the lamina over right side and the separation. Because I injected the methylene blue into the disc space, so we can easily find the herniated disc. Yeah, this dead is herniated disc. Downward, especially for downward migrated disc. So we can expose it and then take it out. So if you are to this contralateral approach for disc removal or for a bipolar disc removal, I recommend this method, injection of methylene blue. It is some good method for making sure in the correct levels and other things. This is curating is a kind of lateral recess decompression. Actually, this video is that video which is published on Neurospine video sessions. This is a post-operative MRI. You can see very well preserved facet joint, especially for the right facet. So big advantage for this approach is that we can preserve facet joint very effectively, especially for the upper lumbar spine. I strongly recommend the contralateral sublaminar approach. This is a comparing ipsilateral approach and contralateral approach. And it's also size of laminotomy. Conventional approach is right side, left side is contralateral approach. And this is a skin closed, skin wound.
Facet joint removal is a very good indication for a contralateral approach. If you have a contralateral approach, the dissection between dura and the facet joint is easy compared to ipsilateral approach. And the preservation of facet joint also have advantage. And in this case, right side hard disc. So normal doctors have a laminotomy for the right side. But if you have left side contralateral approach, you can decompress, you can remove, you can decompress lateral recess more rapidly and more easily. This is another case for a contralateral approach. So this is asymmetric stenosis. If you have asymmetric stenosis just like this, please have less severe side, make keyhole in a less severe side, and then have access sublaminar approach. You can decompress with the preservation of facet joint. And if you have contralateral approach, the dissection between OLF or facet sheath from the dura is very easy because we can find the normal flame more easily. And this is another case for my surgery, central canal stenosis, and combined with the foraminal narrowing. It means foraminal compression over external root and the lateral traversing root compression by the lateral recess. If we have a contralateral approach, decompression over lateral recess and the foramen. So we have to know the anatomy of ligament flavum. Attachment to ligament flavum is very important. Cranial attachment ligament flavum, if you follow the cranial attachment ligament flavum, you can meet inferior margin of proximal pedicle. This is another case, foraminal narrowing and lateral recess compression. And this case is for central canal stenosis with downward migration. If you have a contralateral keyhole, you make cantilateral keyhole, you can decompress the central canal decompression and the downward migral disc with the preservation of a facet joint like this. It also has complications such as hematoma and CSF leaks, and remnant disc. Most common complication is hematoma. So you have to keep drainage after your surgery. In conclusion, with the contralateral approach, we can preserve facet joint more effectively. And sometimes we can decompress two roots, extending root and traversing root. For foraminal decompression, usually we have a so two root decompression, we need the ULBD, interlaminar approach, plus paraspinal approach. But if we have a contralateral approach with a single keyhole, we can decompress two roots. Thank you for your attention.
Hello everyone. This is my video for contralateral approach. Actually, for me, actually, all the right side region is decompressed with the left side approach. It means the contralateral sublaminar approach. But on the L5S1, because the L5S1 laminar wide, so laminar is very wide. So I like to have, instead of a contralateral approach, only I like to have left side standing and the skin incision on the right side, and to decompression on L5S1. But above the L45, for right side region, I always have a left side contralateral sublaminar approach. I hope this video could help to you.
Of course, Professor. Thank you. Thank you so much for that excellent presentation. I have a small question. If you are operating on the left-sided pathology and if you are operating on right-sided pathology, do you change the scope from 0 degree to 30 degree, or is it always the same?
Yeah, actually, there are if we need some foraminal decompression, it means left side making left side keyhole, and when you decompress the right side foramen, we need 30 degree endoscope. But another case, there is no need for 30 degree in my case. So when I need 30 degree endoscope is for a primary decompression through the contralateral approach. So I know, Dr. Ketan, I know what you mean. Your question, the meaning of your questions. So some doctors for left side they use the 30 degree endoscope. I believe if you use 30 degree is more comfortable for you. 100% I agree with you. But I am a neurosurgeon, so I'm very familiar with 0 degree instead of 30 degree. But now I have a lot of experience for bipolar, so 30 degree also very familiar to me. But you have to know when using 30 degree means that there is some dead space, dead area. It means you can lose your instrument sometimes. If I have time, I will explain it more detail.
Hello, Professor. Dr. Shaishav this side. Hello, Professor.
Dr. Shaishav.
Good morning.
Can I see you? Can I see you? Oh, yeah.
Hello.
Good to see you.
Same here, sir. Just one more question. Do you use these dyes, methylene blue dyes or the indigo? Every time you...
Nowadays, I am very familiar. So, as you know, when you stay in my hospital, I use nearly every time inject endocrine. But I'm very familiar for my surgery, so I don't need for injection of endocrine. Without injection of endocrine, I can do everything. But if you start your surgery for removal of hernia disc, injection of endocrine through the transforaminal, it must be very, very helpful for your surgery.
Hello, sir. Good morning. Dr. Parvez here, sir. How are you?
Pavel, sir.
Yeah,
Good to see you.
Nice to see you here.
Yeah, you look good.
It's very nice talk, sir.
Yeah.
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 Okay.
Thank you.
Thank you very much.
Good to see you.
Yeah.
Yeah. Okay.
Thank you, Professor.
Yeah. Sure. Great.
Shankar sir, next talk.
Okay, how are you, everybody? Actually, Dr. Ketan?
Yes, sir.
Can I talk shortly?
Yes, sir.
Time? Actually, bipolar, for my experience, right side, for a right side hand surgeon, right side surgery is very difficult. So sometimes some doctors want to use left hand when they have to right side pathology. So that's why I developed sublaminar approach. So if you can use both hands, you don't need for sublaminar approach. But if you are right-hand surgeon, maybe you have to learn the sublaminar contralateral approach to decompress right side. So the other advantage is fast joint preservation.
So there is a question from Dr. Shankaracharya. He is asking, what about left-sided surgery? Will it be difficult, or you'll remove more facet when you're standing on left and operating left lateral recess?
So sorry, let me know your question again. Yeah, I cannot understand.
If you're operating a left-sided pathology from standing on
left
left
side pathology,
standing on left side.
Yeah. So I need our pathology left side. Okay, you don't need a contralateral approach because left side bipolar is so much easy. Do you understand? So for a left side pathology, usually I stand the left, nearly always I stand the left side and do a bipolar surgery. Only right side region, I like to have a contralateral sublaminar approach.
Thanks, Dr. Park. My question
Yeah,
is,
how are you?
I'm Dr. Shankaracharya. I'm not an endoscopic spine surgeon, but I'm very keen to learn. And it was a nice lecture, but I got a little confused. I am a left-sided surgeon. I do everything with my left hand. So what
Yeah,
is your
yeah,
advice for a
yeah,
left-sided
yeah.
surgeon?
Yeah, you are left-hand surgeon.
Yeah,
You are
I'm a
left-hand surgeon.
yeah.
So most of left-hand surgeon can use his right hand. So you can do, maybe you can use also right hand. So I think I never been a left-hand surgeon, but
So I have to come
it
and
is
meet you.
only everything is reverse. Everything is reverse compared to right side hand surgeon. So you are left side hand surgeon. So you are right side surgery much more easier to you, I think. Do you understand?
Yes, sir. Okay, sir. Thank you. Thank you so much for being with us. It was wonderful to listen to your experience about sublaminar approach. Thank you. Thank you so much.
I really appreciate your having me. India is my most favorite country. See you again.
Thank you. Thank you so much, Professor.
May I invite Abhishek Kashyap to give the next talk, please? He's already there on the stage. And he's one of the main organizers along with Rahul. Thank you very much.
Sir, to put your question into answer regarding 0 and 30 degree, if you're early in your beginning learning curve, use the 0 degree because your instrument is going to be end on. When you're using a 30 degree scope, later on you can shift to a 30 degree because it gives you a wide view. So probably you can do a contralateral job very easily when you're using a 30 degree scope. It doesn't matter to us now, once you are in those large number of cases, then it doesn't matter whether you're standing on the right or the left now. But in the initial part, difficulty is there on the right side. You probably have to shift your portals, the viewing portal down to see up, to decrease the level of laminotomy when you are using it on the right side. You need to switch it on. So to put in perspective, everyone is familiar with how you do micro decompressions for lumbar canal stenosis. So when you're using a biportal surgery, you're basically replicating the same steps what you would be using in a tubular surgery in a biportal endoscopy. Everyone has talked about the portals, everyone has talked about how you make your triangulation. So I'll be just talking about how you go about the technique. So what is ULBD? Basically, it is that you go from the ipsilateral side, from the side which is the main pathology, you decompress and then you move to the contralateral side and you do a over the top decompression. And then you see the both nerve roots and you do the job. So that is what is a ULBD is, that you are standing on the same side doing a laminotomy removing the phlebum, moving to the opposite side and removing the phlebum, and you're doing the job. So if you look at the basics of what is stenosis is, I will be only speaking about central stenosis. I'm not going to talk about foraminal stenosis in my talk. So if you look at the anatomy of the ligament phlebum, it's like a butterfly. So you need to remove the butterfly, and there is a midline cleft. So the first step would be to recognize this midline cleft and then removing the phlebum. Dr. Park, who was the pioneer for these surgeries, he plans to remove them like a butterfly. In total, he tries to remove it. In your initial learning curve, do not try to replicate because these can lead to dural tears. I prefer to use it piecemeal. I don't know most of the authors are going for the butterfly challenge or not. So why UB for me? For UB for why I migrated from a tubular disc decompression to UB is because the benefit is of the water pressure. So the water basically pushes the dura away. You can drill easily. The bleeding and the bone dust washes away, so you don't need an assistant. And definitely there is a more magnification as compared to a microscope. Microscope would provide you a magnification around 6x. Or you need a 10x microscope would set you about by 2.5 crore rupees. So I use is a single chip camera and a scope which is available from Amazon, which is just 20,000 bucks. The same set of instruments what we are using for open surgery are used in UB. You do not need big instruments. The only thing you need to invest is into a good drill system and a good RF system. Most of the places where arthroscopy is available, you will have the drill system. I'm using the same core console which is available from Stryker, and the RF is basically, you can ask your sports fellow which RF they are using. So my hospital has a Dynex, so I'm using an Arthrex also. There is available from Bonds, there is available from something from, and local vendors also now have come into an RF. So you can probably look and go into the dynamics which is working for you. So it will not offset you by too much the UB surgery. To answer that question, the first thing is how do you make your portal? For every UB surgery, basically your starting point is the spinolaminar junction. So you move to the spinolaminar junction. Here you will try to triangulate. You try to triangulate and you feel it. So the first incision for all surgeries, for discectomy, for lumbar canal stenosis, I prefer to use the same portals. I make the instrument portal first. If I'm standing on the left side, even if I'm standing on the right side, then my portal will move somewhere around here for the right side, and for the endoscope portal will go somewhere around the lower part of the pedicle. And I will triangulate over here. This is the spinolaminar junction. So initially the portals were around 3 centimeters. Now I'm trying to move towards decreasing the distance between the portals, because that helps me in decreasing the amount of laminotomy what you're doing. So why you need a technique in UB? You need there are two techniques which are described as the N technique and another is the Z technique. They have been more popularized to trying to remove the phlebum. I prefer the Z technique because Ketan is here. Ketan taught me the Z one, and Malcolm is here, I believe. So they both taught me the same technique. Whatever technique you want to use, both have their advantages and disadvantages. But you need to learn and have a mechanism how you're going to go about, because in UB you can get lost. So you need to have a mechanism how you're going to prefer to remove your phlebum. I prefer the Z technique, so I'll be talking about the Z technique. So I think we have lost a video. So in the Z technique, basically, So in the upper part of the laminotomy window, you can use the arthroscopic shavers, you can use the drill which is available from in your hospital, what you are using for your normal surgeries. Use the same kerosene ronger. In the lower part, you would be preferring using the osteotome or the rotating kerosene to reach the far out ends. So this is how we start. I hope the video, yeah, we start drilling at the spinolaminar junction. That's a basic step of all UB surgeries. You start drilling at the spinolaminar junction. You expose the flavum. So you are trying to expose the flavum and you're trying to see this part. So, and you will try to reach the top part of the wing of the butterfly. That's the first part. This is the same RF what we use for the sports guys use, the same Arthrex, the same kerosene rongers. Then you move to the contralateral side. So in the contralateral side, what happens is basically you move and you try to get to the upper edge of the flavum from on the opposite side. And you are working below the spinous process. So you try to go below the spinous process. Do not take down your flavum in the initial part. Your flavum is your friend there. So it will protect and it will let the burr not plunge into the dura and cause a dural tear. So you move to the contralateral side, you drill underneath it, you use your pen fields, make a dissection plane, and you move to the opposite side until you try to feel the sap, the superior articular process on the opposite side. So I have not gone into the epidural space. I am trying to move to the opposite side. I'm trying to feel the sap with the curette and trying to get a plane between the sap and the dissection plane between the flavum. So I can see a small window there in the lower part of the window where I know that now I have reached the limit of the opposite side. So how do you go about removing the flavum in the inferior part is that you need to go to the inferior edge. So the flavum has two layers. One is the superficial layer and one is the inferior layer, which is more thin. So we use the kerosene rongers, the curettes, to get the superficial flavum out. So this is the superficial layer of the flavum. So we're trying to remove it from the inferior edge of the lamina. We use a 3 mm burr to drill the base of the spinous process with the inferior lamina and to reach the caudal part of the flavum, which is the deep layer. It's just a replication of the same steps what you do in a tubular surgery. I have not touched and removed the flavum till yet. The flavum is your friend. Keep the flavum intact till you complete your bone drilling. I'll try to rush into the video. So this is we are trying to remove and getting the flavum out from the inferior edge. So you can see a small hole there. Now the flavum has been dissected from the inferior edge. Okay, so you can see a small window of the epidural space. We'll probably get our pen field inside, and you will probably try to get the whole flavum out. Then you move to the opposite side and you try to get the flavum out. You can do it either by a single piecemeal manner, or you can do it taking small bites. I would prefer that in your initial learning curve that you try doing, see what you are grabbing, try rotating, do not try to pull anything. You can have a dural tear. So this is the contralateral side flavum. So we're using the pen field dissector. We're making a plane. Once we make a plane, the water basically enters into the plane and it pushes the dura down. So you have your instrument can go inside and help you in grabbing the flavum and getting it out. So we're trying to get the whole flavum out in one piece meal. Sure. And we're working at the inferior edge, the caudal, where the nerve root would be. You can beautifully see the sap. You can see the inferior articular process and the sap. So this is the place where your traversing root would be. This would be the zone where you need to decompress. The ipsilateral flavum is still intact. And we move towards the ipsilateral side to get the whole flavum out from this side also. Get a whole chunk of flavum out. And you can finish removing the flavum, decompressing the normal side. So just a replication of the same steps of what a tubular discectomy would be. Some part was left on the contralateral side. We try to grab it, the whole part, and we remove it in one piece, toto. Do not try to pull anything. Try rotating your carisson or your pituitaries and try rotating it and getting them off. This is the, you do the lateral decompression. And the end would be in front of you that you've done a complete central decompression. Since this patient was at L3, L4, and patient had symptoms only on the left side, so we only decompress the lateral recess on the same side. So this is where our water was over. You can see now the bleeding has started happening because the water pressure went away, the flow happened. So now the assistant has put another bottle of water and the field becomes clear again in front of you. So this is how we are decompressing the lateral recess. We try to feel with our carisson ronger the pedicle on the inferior part, and we decompress the nerve root. So I can see the shoulder of the nerve root now. I can see the shoulder of the nerve root. I would use a pen field to do the adhesive lysis on that side. So it's the same replication, the same steps what you do for a tubular decompression is. So So this is the patient what I was talking about. This patient had a multi-level stenosis, but her more symptomatic level was the L3, L4 level. With a central stenosis, she had left side leg pain. So we've done an adequate job. In the initial part of your learning curve, you would spend around 1 hour 30 minutes, and now we have moved around to 45 minutes in decompressing just one single level. Okay? Thank you. Thank you so much. We'll try to replicate the same steps in the cadaveric workshop.
I would now like to call upon stage Professor Dr. Rajni Ranjan to present a memento of our gratitude to the speaker. Let's begin our inauguration ceremony. I would like to welcome Dr. A.B. Singh, Dr. V.K. Gautam, and our MS sir to join us, please, here. I request the MBBS music band to come out for Saraswati Vandana. I request Dean ma'am to please join us on stage.
कमल तेरा आसन है, श्वेत हंस तेरा वाहन है, श्वेत कमल तेरा आसन है, श्वेत हंस तेरा वाहन है, हम पर सिद्ध दृष्टि कर जननी, बोध चीर की धार दे, वीणा पानी तार दे, तार दे, तार दे, माँ सरस्वती शारदे, माँ सरस्वती शारदे। शारदे माँ शारदे, शारदे माँ शारदे।
I would now like to request our faculty seated at the dais to please proceed with the lamp lighting ceremony. I would now like to call Dr. V.K. Gautam, our head of department and omnipotent presence in our lives, to say a few words. Thank you, sir.
Respected Dean Madam, Medical Superintendent, Sharda Hospital, Dr. G.K. Singh, President of the Noida Orthopaedic Society, and other dignitaries on the stage and off the stage who have come here to demonstrate their surgical skills on endoscopic spine surgery. Historically, the spinal surgery has been seen with a lot of disdain. In the past, in the times not as old as 1970s, anybody who broke his back, it was idiomatically said, yes, he broke the back. That means you cannot get up now. And there's a Hindi counterpart to that, iski to kamar hi toot gayi. That means anybody who has injured his spine is unlikely to recover back. We have seen, I joined MBBS in 1973 and AIMS 1979 January. I joined and I've seen in these premier institutions also, patients dying with bed sores, urinary tract infections. All these advances were not there. In the north, only 3 orthopedic surgeons I can remember when they were there when I was a student. Professor Prakash Chandra, he was the Dean of the All India Institute of Medical Sciences. He only used to do foraminotomy and discectomy, which I picked up and I started doing. And Professor P.K. Dave, of course, he was the director of AIMS subsequently. He used to do scoliosis surgery, and we used to assist him 8 to 9 hours continuously. Harrington rod was in vogue that time. There was no anterior surgery, putting spinal hooks, distracting the spine, and fusing the spine, Harrington rod. So we did develop interest, but it was very labor-intensive, and many of the people got dissuaded to some extent. And you need a very big setup to start a spinal surgery. You can't go in a nursing home and start big spinal surgery. So subsequently, I joined PGI Chandigarh, and there spinal surgery was not done at a very great scale. Joint replacement is in vogue, so I got fascinated to joint replacement surgery and subsequently did some fellowship in joint replacement surgery, and that is my present interest. So in early 1980s, there were very few takers. In fact, the people who were doing joint replacement in spine, they were not letting us do. But then there was a hidden zeal inside our mind that we want to do it, and ultimately people started developing all these techniques. People, in spite of significant advances in spinal surgery, people are still people means patients are still very critical that somebody should touch their spine. I get 5 to 6 consultations almost every month where people have been advised surgery, and they feel that spinal surgery is not very safe, and they want to take an opinion, is there any other way this patient can be treated? So in fact, many of the disc prolapses, 90% of them can be treated conservatively without any surgical, endoscopic, any procedure. So some of my most grateful patients are those whom I advise against surgery. But subsequently, with the advent of endoscopic surgical procedures in the spine, I'm sure that gradually we are removing all the disadvantages of an open and prolonged spinal surgery, and ultimately we'll be able to motivate people to get this surgery done, which is much safer, much less complicated, and faster. So with this, I wish all the best for this conference, and very best. And afternoon, we have a cadaveric workshop, which will be a hands-on workshop, and to the budding endoscopic spine surgeon, that will be a big feeling, because nothing can replace a hands-on experience. You can't read books and do a procedure. Just like you can't do swimming by reading a book, you have to jump into the pool. So cadaveric surgery is the best surgery. Even open surgery and other surgeries, NMC has dissuaded now, because patients' interest may be jeopardized. Cadaveric surgery is the best. There's no hurry. You can stop anytime you feel like. So I think with these words, I would like to thank all those people who have come here. Thank you so much, sir.
I would now like to request our Dean Ma'am, Dr. Nirupama, to please grace us with a few words.
Thank you so much. Dignitaries on the dais, we have from the Greater Noida Orthopaedic Association, MS Sharda Hospital, we have Dr. HOD Orthopaedics, Dr. V.K. Gautam. Besides that, the senior professors from the Department of Orthopaedics, Dr. Rahul Kaul is there. All the dignitaries, the delegates who are present here. I welcome you all for this national CME on biportal spine surgery endoscopically with a cadaveric hands-on workshop in the dissection hall department of Anatomy, School of Medical Sciences and Research. Best wishes to the organizing team, and I request Dr. Rahul Kaul and the head of the department orthopedics to take this forward, and it should be a great learning for all of us. Thank you so much.
I would now like to request our MS sir to please grace us with a few words.
Good morning, delegates. Dean SMSR, Dr. Nirupama Gupta, Dr. VP Singh, President Greater Noida Orthopaedic Association, Dr. VK Gautam, Head of the Department of Orthopedics, dignitaries, delegates, my dear students. I am very glad that Dr. Rahul Kaul had taken this initiative to organize this workshop on endoscopic spine surgery. In fact, when Dr. Rahul came to me about 6 months back, sir, I want to organize this workshop on endoscopic spine surgery. I was not very clear what he's trying to do. What is this so-called endoscopic spine surgery? I asked him, can you do endoscopic spine surgery? He said, yes, sir, nowadays we can do endoscopic spine surgery. So I got slowly convinced, and today I saw the final result. Dr. Rahul Kaul had taken this, and with the help of the department, completely. Endoscopic surgery started a couple of decades back. Initially, surgeons started doing laparoscopic surgery, cholecystectomy, then other surgery. Nowadays, almost all the surgery are done laparoscopically. So I feel why orthopedic surgeons should be left behind. So they are also venturing more and more into endoscopic surgery. And now somewhere in between comes robot also. Robot also is there to play the role along with the surgeons. So basically, technological advances brings newer thing to the medical field. And this endoscopic spine surgery is also one of the results of the technological advancement, I feel. Technology brings new thing to us, and we take up the new ventures, new things, we start and trying to cure our patient. Another reason I feel is because of aim is to go for minimally invasive surgery or minimally access surgery, what is called, so that we do not give a big cut on the patient body, patient feel minimal incision, and to reduce the pain, discomfort after surgery, and to also to cut down the risk of hospital-acquired infection. That is also one major thing coming up nowadays with more and more MDR bugs becoming more common, antibiotic resistance becoming more common, and any infection in orthopedic surgery is a major issue. I'm sure nobody wants this kind of thing. And as Dr. Gautam said, a decision to undergo spine surgery is very difficult. Patients will undergo years of pain, back pain, but will not take a decision for surgery. Because many people say, no, spine surgery will never benefit you. Do not undergo spine surgery. So they keep on trying physiotherapy, various kind of other therapy, but will not go for the spine surgery. But I'm sure with the endoscopic surgery available now, minimally invasive or minimally access surgery, with a minimal pain, minimal discomfort, minimal chance of infection, our patients will be more and more encouraged to go for endoscopic spine surgery and not tolerate and bear the pain for a long time. With these words, I wish all the best to all the delegates, and I wish this workshop is definitely learning point and will definitely bring new changes in our practice of medicine and orthopedics. Thank you. Thank you very much.
I would request Dr. A.P. Singh to please grace us with a few words.
Respected Director Ma'am, MS Sir, Gautam Sir. On behalf of Greater Noida Orthopaedic Association, I welcome all faculty members and delegates for this exclusive bipolar endoscopic spine surgery. I think this is the first spine surgery or any orthopedic conference we are organizing here in Greater Noida. And we hope for further conferences at Greater Noida Institute of Medical Sciences. There are 2 medical colleges already functioning very well, and third is also Noida Medical University is also going to. So future is here. So many conferences must be going on here. So I congratulate to Sharda Hospital and Department of Orthopaedics for conducting this exclusive conference. I wish for the delegate a very good learning on cadaveric workshop. Thank you very much.
I would like to invite on stage Dr. Rakesh Kumar, a professor in my own unit, to help us present a memento of our gratitude to the dignitaries on the dais. I would like to request the delegates to please step outside for a tea break. Thank you.
want to do it through a single set of incisions. So what do? I bring the two together. I just bring the lower upper mass a little down, skip one lateral mass, go to the third lateral mass and bring that a little up. Try and come within the range of around 3 centimeters skin distance, and then you can do both routes. You can do both routes very comfortably. So this is one route which is decompressed, and then you can skip over the lamina and go to the next route. Now this is the advantage again of a 30-degree scope. You don't need much of struggle. You can literally sit on the middle lamina and just tilt your scope this way, that way, and get your vision. Let us come to pedicular osteotomy. Sometimes I need to do a pedicular osteotomy. The nerve roots tend to be quite large. Discs sometimes are collapsed, and you do not get space in the axilla or on the shoulder, and you want to remove a disc there. So for better visualization of axilla or shoulder, in cases of foraminal stenosis where it is not possible for even a 1 millimeter kerrison to approach, and the root is badly trapped under the shelf, you need a pedicular osteotomy. In case of adhesions and plastering of a nerve root, you need a pedicular osteotomy. So we're going to play this video. I had done this in the Third World Congress. It was a live case. And here you can see how I'm breaking the pedicle on one side in an oblique manner, removing it, and then putting a hook below. And you can see how the hook is able to just enter that shelf to help me decompress this root. But this root was totally plastered. So for a plastered root, you require a very fine RF probe, which can then gently go by the side of the root, remove those adhesions until you see the outer twisting pedicular corner. Because when you see the outer pedicular corner, it means your root is now free to enter the neck. So when I move away this root, you can see both the pedicular corners. This video I presented in the first French UB Congress because I think I was the first person in the world to do an over-the-top decompression. And this was then later developed further by Master Son. But here you can see that in a cervical spine, it's very easy, after cutting partially the base of the spinous process, to cross over on the opposite side, enter the opposite foramen, decompress the opposite foramen. Here was a stripped, adherent flavum to the dura. So we did an en masse stripping of this flavum to decompress the myelopathic component also. So it is not possible, it's not impossible to do an over-the-top in the cervical spine. It is regularly done. And subsequently, the Koreans even developed a complete laminectomy technique, though I don't agree with it. Those are personal issues. We won't go into those right now. But you can enjoy this radiological appearance of a scope on one side, and we are out of the foramen on the other. Sometimes you have a combination of pathologies. Here at C45, I had to do a foraminotomy, and C56 had a central anterior disc. Sorry. So I decided that I will do a cervical foraminotomy posteriorly with the UB technique and put in a small 4 mm anterior endoscope and remove the fragment at C56 anteriorly. So this is doing the foraminotomy, freeing up the root on both sides, seeing the pedicular exits, doing a little bit of flavectomy to decompress the cord, and then putting in an anterior cervical endoscope. You can see that the sheath is placed directly at the PLL line, opening up the PLL gap. You can pull out the fragment. Unfortunately, this is a honeycomb lens, so it does not have the same clarity, but you can see the fragment is out and the dura moves with the water column. Now let's come to what has been my current muse, my current love, and that is myelopathy and the evolution of ACDF the way I have done it, and the role of hemilaminectomies in myelopathy. My first evolution was to use a standalone peak cage. Subsequently, I decided to do a decompression and a standalone peak cage with locking screws, but inserted visually the way Dr. Kang Taek Lim does in South Korea. And lastly, then I said, okay, if I can put in the cage, maybe radiologically, but why not put in the screws endoscopically? And why not make it a complete endoscopic picture? So let us see the 3 videos. Here you can see that I have reached the posterior vertebral edge. I can feel the osteophytes. I'm probing the superior vertebral edge. I have completely removed the disc. I'm probing the inferior vertebral corner, making sure that there is no osteophyte discal fragment remaining there. And subsequently, you can see how that hook engages and pulls out from the center a fragment that is still stuck in the PLL, gradually mobilizing that fragment. But now I'm using a stenoscope on the neck. I'm not using a normal 4 mm scope. You can see how I prepared the end plates. I use a variable angle tip burr that is manufactured by Richard Wolff. I think I was the first person to purchase this in 2015 when it was first introduced. It's a 3 mm burr tip. It's diamond tip. It's pretty safe. And because of its variable angle, it allows me to cut towards my side and the opposite side the way I hold the burr. Now, having created the trough properly for the cage and identified and removed all the fragments, identified the PLL, try and preserve some of the PLL if you do a little extra cutting of the end plate. And this is a kerison doing the remnant work just above the dura. And this is the strap muscle on my side, strap muscle and the esophagus on the opposite side. You can see the rent in the PLL. You can see the dural cord very nicely. And now I will be introducing a peak cage. Now the peak cage, what you do is you used to put a rod through the scope, engage the cage to it, and slide the cage in. Release it, but I feel that the cage is facing me too much. It's not facing properly, it's not centered properly, so I'm re-engaging it with a rod through the scope again. And I will be correcting the positioning of this cage. So, re-engaging the rod, doesn't get through first time. Now in these kind of cases, you try and preserve the anterior lip as much as possible so that after the cage goes in, the anterior lips close. The cage is large, it's 14-17 millimeters in width. So because you have pushed it in, after that and rotated it, it gets locked in place. So this was the first evolution of ACDF I had done. This again I had presented about 3 years ago. What do you do when a patient comes to you with an unstable segment and focal myelopathy? It is instability causing the myelopathy. You have a subluxation over here. So what am I going to do? So I decide, okay, I'm going to do an ACDF the way Dr. Kang Teklim does it. So I go in, I put in my guide wires, see that your needle is in the center, the trachea is moved to the side. You're comfortably placed in with your guide wire. Use your serial dilators. I have a set of dilators that go right up to 10 mm. And I dilate up to 10 mm, then remove the dilators, and finally start with the discectomy. Here comes out the first loose fragment. And then afterwards, using a full endoscopic plasma wand and also a long UB type of wand, 90-degree wand, using the burr, create the end plates, remove all the discal material, finally see a fluttering dura over there. You make sure you're absolutely comfortable, and then introduce a cage. Unfortunately, this cage was slightly to the opposite side. It was pretty decent, patient is comfortable. I am not a troubled surgeon until he comes back with an adjacent disc disease. See, this case is an interesting case. Huge herniation, myelopathic cord changes. This patient I did in Baroda with Dr. Kiran Jaiswal assisting me. And you can see even in the CT scan, a very horrible presentation. This patient was myelopathic for quite a few days. He was spastic. He suddenly comes with quadriparesis. So I suspect that there is a soft fragment with a hard shell. So I decide, what should I do? So before I go into the video, you can see that I've placed the cage at the end of the surgery. But the third image, that third image below there, that is important. That is in the opposite zygoapophyseal joint, breaking the osteophyte there. So let's play this video and let's enjoy this video. Now, what I do in this video is I decided I will first do a posterior global decompression. I'll go posterior and save my cord. I'll secure my cord. I want to release this pressure. So I do a hemilaminectomy of the lower vertebrae. You can see these images once again. They're horrible. So I do a posterior C6 hemilaminectomy, partial hemilaminectomy of the C7. I go to the shoulder of the pathology, find the soft fragment and pull it out. But you can see how wide this cord is. I put in a drain, turn the patient around. And then I start the anterior cervical, ACDF and discectomy. So again, you see the guide wire, see the centering of the guide wire. Unfortunately, in this patient, the shoulders were too high, so lateral was not possible. This whole surgery is done in the oblique and AP views. You can see at the end of the treatment, there's a black corner up there. That was the Surgicel that I had introduced over there from the posterior surgery into the disc to tell me where is my opposite zygophysial corner. Then decompressed along the midline, fluoroscopically hammered in the cage when I was scared because I had no lateral, and then finally realized it's a little deep, so I had to take my burr and cut the bone edge a bit to introduce a screw through the scope. This was difficult, but it was possible. We had to struggle quite a few times, but we were able to do it. And come to the next slide. This is with the patient's permission, 2 weeks post-op, still some spasticity, recovered from quadriparesis, walking around quite nicely. I will go to the next thing that I love the most, and that is dealing with multi-level myelopathies. Now, for a kyphotic neck, I have nothing to say. Please do what you want to. But if you have a neutral neck or a K-line negative neck, then UB does give you an answer. So here you can see multi-level involvements, but the majority of the involvements are all on the left side. Patient had left 3-root involvement. So it is a myeloradiculopathy with only one-sided, one limb involvement in sciatic pain or radicular pain. AP lateral X-rays, flexion extension X-rays, not showing much of instability. What do? I do multiple level of hemilaminectomies, keep the tips intact, and then decompress. So let us see the video. Before I start this video, you can see the root in a horizontal manner, flowing out of the neck. As I start the video, I rotate my camera and you will realize the orientation of the root. This is the second root which I have exposed, and I'm removing the lamina from between. Freeing both and connecting both the roots, removing the lamina, and doing a flavectomy across the midline. It is the flavum and the base of the spinous process where it attaches, which causes the maximum compression posteriorly. So keeping everything intact, and then going for the third level and removing that lamina after doing a foraminotomy there. So the net result is I have removed 2 laminas, hemilaminas on one side, connected through roots like bridges, exposed everything. Patient had a transient C5 palsy from which she has recovered very well. I'm grateful to God for that. 97% of them recover. But preoperative counseling of its possibility is very important. And here I'm lucky. So the bottom line is that I have done 3 levels of decompression. Now I want you to see this image. This image is very important because in the nuchal ligament you have a funicular part and you have an intermediate part. Now when you do an endoscopic complete laminectomy, you tend to destroy the intermediate part, though you retain the funicular part. And then retaining a small tip does not make any sense because you have removed the entire bridge and the whole lamina. Therefore, this nuchal ligament is like a rubber band without tension. So therefore, these patients would then progress to swan neck deformity, and that is why I shifted to hemilaminectomies. You see this redacted image. I have removed the vertebral bodies in front. I asked my CT tech to remove the vertebral bodies. And you can see the amount of laminectomy I have done and the 3 roots which I have decompressed. You can even see that in these sagittal images. Now this case got published recently by me. This was a case with bilateral myeloradiculopathy. What happens when you have myeloradiculopathy in both limbs, multiple roots involvement, long segment myelopathy? If I were to do a laminoplasty, then what do I do on the side where I put up the bridge, where I've done a partial break? I can't put screws there. I cannot do a fixation there. Even Kurosawa's technique will fail. What do I do? So I decided to do step ladder hemilaminectomy, connecting the C3 to C4 to C5 to C6, C7, and doing a 3-level decompression in that manner. And the best part is we followed up with this patient over 2 years, and what I can show you here and what you see here is there is a fusion that has occurred here. You can see there is a fusion mass over there. The facets are fused. See this pre-op, see the 18-month post-op, and there is no progression of the swan neck, nothing there. So, endoscopy is the future. We are all moving towards it. We don't have all the definitive answers. We all agree to disagree. Motion preservation is the new gold standard, not ACDF. Overall, it is low cost and effective. When you use UB with monoportal, the costs rise a little bit. It is far more versatile, especially when bilateral roots and cervical myelopathy is involved. You need to master all forms of endoscopy. Please don't stop. Be good. I mean, you all are born to be good. You're born to be excellent. You're born to be better than all of us. Endoscopy is easy, and with a good mentor, we have got very great teachers sitting here in the hall who teach very beautifully. Endoscopy is a very short learning curve, though whatever anybody may say, it's all your perseverance and persistence and dedication to it. Endoscopy was ignored. This is the way we were ignored. Now hopefully people will acknowledge us. Thank you.
Do we have any questions? Fantastic cases and talk, Madam Malcolm. I think it's making work. Do we have any questions from the audience for sir?
But this is the only lecture on cervical problem, so better to finish with the questions right now. You are the only one speaking on cervical, I think. Can you use the mic, sir? Questions and answers? Yes, any questions to them? Because I understand very few people must be practicing cervical UBE. Is it compared to?
So for your anterior cervical,
I think all my boys over here are practicing it, sir. And they are all good at it. Rest assured, all of them.
Dr. Manish. Can
Thank
we
you,
have
sir.
mic for?
Or for mic?
What your landmarks would be, how would you go about doing an ACDF? That is one.
Yeah.
And secondly, I mean, the classical teaching has single level radiculopathy, cervical disc, say 5-6, having a unilateral radiculopathy. How would you approach it? A UB posteriorly or a regular ACDF anteriorly?
Yeah. So, unfortunately, a talk doesn't cover the entire spectrum of teaching, so please forgive me there. What I do is, this chapter has been printed by me in the World Book on Endoscopy. What I do is I just put in 2 fingers here under GA, because it's a little uncomfortable to do it under local. There are people, I mean, Dr. Nadkarni who taught me used to do it under local. I used to do it under local, but I moved away from it. I prefer GA now. You just push the tracheoesophageal complex away with your 2 fingers and press down so hard that you can feel the vertebral bodies. Now, under a C-arm lateral, and you know that this is my AP, you approach and dock onto either the vertebra or onto the disc.
So you
And then you can crawl a few millimeters up or down and enter the disc you wish to.
So you would make a small incision and then use
One,
your dilator.
no sir, I don't make an incision also in the initial stage. It's just a needle. It's a long 2 millimeter thick needle It's manufactured by Karl Storz. It's pretty rigid. You just introduce the needle and you hit the approximated targeted vertebral body. Now, vertebral bodies are not too big. 2 millimeter up, you're in the upper disc. 2-3 millimeter down, you're in the lower disc. You can literally walk your needle and enter the disc. Now, once you locked into the disc, you straighten up your needle. So you push the tracheoesophageal complex further away. Now you have achieved verticality. I need verticality to put in my cage. If I'm doing discectomy and I have let us say an anterior paracentral disc, right, and I'm coming from the left, my glide path will take me directly to the disc. So there I don't need to achieve verticality. But if it is ACDF, I need to make the needle vertical. That's why I showed you in that X-ray view, CM views, the needle must be vertical. Remove the needle, put in a guide wire. Remove the guide wire, put in a 2 millimeter dilator. It gently tears through the disc and docks onto the, see the neck is bent like this. So when you bring in a wire like this, it is going to hit the upper vertebral body, unless you are like this. So in the initial stage, you don't be vertical, you be in the sagittal plane, you be about 5 or 10 degrees downwards. So you will hit the upper vertebral body, serially dilate your path, then you can go up to a 10 millimeter dilator, which will never enter, but then it allows you to establish a port over there, a steel tube that directly sits on the disc, remove everything from there, introduce your scope, introduce your stenoscope, and you start your surgery. Now comes the question of how do I put in the cage at the end of it. So initially, because it was a peak cage and I could put it, connect it through a rod and put it, I felt it was easy. Then came the evolution here. Kantek Lim started showing his work. I am putting in screws, so I was wondering how is he putting in his screws. So we all follow each other a little bit. Then I said, no, he puts in a simple retractor at the end of the surgery, puts in the cage and locks the screw. I said, why not evolve one stage further? Why not go one step further? If I can endoscopically introduce the cage, if I can endoscopically put in the screws, it's the same thing, it's the same approach, it's the same Smith-Robinson's approach. There's generally no difference, sir, except that because we are dilating our path and doing it gradually, we don't have worry about bleeding, vertebral artery injury. You have mythical fear that I will enter the esophagus, but it doesn't happen that way. So after a few hundred cases, I can assure you, you will do it beautifully. You will do it beautifully. In your first case, it took me 100 years to evolve to that. That's why I said you guys will be better.
With your experience, I mean, definitely, but you make it sound simple. May not
so I hope I answered both your questions.
Yeah.
Regarding discectomy, and if there's a posterolateral disc herniation, you can do it very easily
my question is that
by UB, posteriorly.
If you have a regular case walking into your OPD, having a single level radiculopathy, what would be your first
Sir,
preference?
if the offending factor is a disc, posterior UB. If it is a disc osteophyte complex, posterior UB, you just need to dhakkan kholna hai, sir. Thoda dhakkan kholna hai by 4 or 5 millimeters of the facet, the root is free because no osteophyte is so large that it can continue causing pressure on the root. You don't even need to go for the osteophyte.
Dr. Malcolm? Sir, this side.
Yeah.
So the cage that you inserted, which you showed, is a regular peak cage and the regular construct?
Regular titanium peak.
So
Aosis,
it goes through your sheath of the cannula for the scope that you're using?
Sir, because I'm using only a small stenoscope, the rod of the cage, you just push it through the central working channel and you lock the cage in front.
So does your size of the cannula limit the size of the cage that you can put?
You need to, you asked a very important question which actually I skipped. There what I do is I remove that cannula and I use a cut cannula. It's got a cut in it. It's got a sleeve cut in it, so it allows me to slide. It's like a slider. It allows me to put the cage in. I'm sorry, I should have stressed on that.
And one last question, sir. You mentioned about multi-level compression, multi-level cervical spondylotic myelopathies, with specifically you mentioned K-line negative, in which you're doing posterior approach. Now, the classical teaching and most of the studies, they have shown that in K-line negative cases, the anterior decompression works and gives far better neurological recovery as compared to posterior. Because K-line negative essentially means you're working a kyphotic spine. And by posterior decompression...
So that's why I said, so leave kyphotic spine out. Yeah. And the first thing I said, okay, don't talk of kyphotic spine because that has to be done anteriorly. So I would also do the same ACDF, endoscopically at 3 levels if I have to.
Okay.
I would not dare to break there, the norm. But where the conceptual change is this, sir, that if you go to see any consensus paper by AO Spine, I will not name people. People say that if patient is between 12 to 14, 15 MJO score, don't touch the patient, observe the patient. If it's only patient deteriorates after 12, do you intervene? Now this is not justified, sir. If you are a spine surgeon and I tell you, you wait till you develop spasticity and then I will operate you, will you accept it?
No.
Then why do you advocate that to people? You have no answer for that, sir. UB changes the paradigm. Believe me, I have done more than 50 cases with electrophysiological monitoring. I did not have a single run, not a ping on that bloody machine. And I was challenged on this in South Africa. I did 15 cases in 3 days on cervical spine. At the end, they were scratching their heads. I have not showed you a video, but I can show you a video also later on outside. We have done a series of patients where you have injected contrast. It doesn't go anywhere else, but just comes out. It doesn't even go more than 1 level up. So there's a lot of myth and misunderstanding there. There are 3 components to any myelopathy. Edema, reversible. Myelomalacia, reversible. But axonal degeneration, non-reversible. Now, if I can give you something in a stable spine, multi-segment, patient having a bad neck, I don't want him to deteriorate. I'd rather operate him, relieve his myelopathy in a very safe manner. And I'm not scared of what I'm doing. The other problem with the traditional, any neurosurgeon will tell you, with the Schofield's approaches, there is 43% scar pain. With UB, we have 0 scar pain. We have patient walking around the same day, evening, eating, going out and sitting in the balcony. That is the difference. We have a small drain and a small dabba stuck over here on the shoulder of the patient. That's it. No collar, nothing. I give my patients a pillow to use. And they're comfortable. It's only when I've done multi-level, multi-segment, yes, a soft collar for the first 1 week or so until the patient gets his balance back. Because they're spastic and you don't want anything going wrong. That's it, sir. It's very safe, sir.
Great.
It's very safe. Thank you. Thank you so much.
Any further questions? So I think, thank you, sir. And we would now invite Dr. Ketan
I would
Deshpande.
request Dr. Anil Joshi, Professor Emeritus, and our past HOD to present our speaker, Dr. Malcolm, with a token of our gratitude.
Thank you, sir. So I have now the pleasure of inviting Dr. Ketan Deshpande, who will be speaking on UB paraspinal approach. Again, a technically demanding and an innovative approach to deal with the paraspinal, foraminal and far lateral pathologies.
Good afternoon, everybody. Firstly, I would like to thank Dr. Rahul sir, Dr. Abhishek sir for giving me this opportunity to present my work. It's a very simple topic, UB paraspinal approach, where we already know how we perform the, like a will say approach, and the indications and the overall approach is quite similar to what we would do in an intertransverse kind of an approach or a paraspinal kind of an approach. Where we want to go slightly lateral to the facet joint dock or the lateral aspect of the superior articular process or the pass and do the procedures. The indications are foraminal to extraforaminal pathology. Also, a newer indication that I've started doing is a central disc for upper lumbar levels where the facets are quite vertically oriented, and if you take a entry lateral enough, you can actually go right up to the midline, and you can remove a central disc where it's at the level of the conus and you don't want to manipulate the nerve roots too much at that particular level. I have a case also that I'll be discussing with you guys. Can we reduce this light intensity, please? सामने का light थोड़ा सा कम कर सकते हैं? I do the procedure under general anesthesia, prone position, just like a microdiscectomy. We use two portals, which are both at the tip of the TP of the target level. So after squaring the particular vertebra, the first portal, the scopic portal will be marked like that. The working portal will be marked like this. And we'd like to triangulate somewhere over here. If it is a very hypertrophied kind of a facet which is overhanging the Cambin's triangle base, I would like to dock directly at the SAP. If it's a vertically oriented facet, you can dock anywhere from pars to lateral aspect of SAP, depending on how the facet is oriented. So we'll just look into the step-by-step procedure. The first incision will be 1.5 centimeter incision over the lateral most part of transverse process of the caudal vertebra. So in this case, it's an L4-5 extraforaminal disc herniation starting from the tip of L5 TP. I'll take the point, I'll mark the incision somewhere over here. I'll go straight in, hit the transverse process, walk over the transverse process, go medially till the medial most point of the transverse process where it joins with that of the vertebral body. So we'll take the incision and with a blunt tip obturator, go straight down onto TP, walk over the TP and reach to a point which is somewhere over here. The second step is to mark the working portal, the scopic portal. This will be around 1 centimeter incision on the tip of the cranial TP. Again the same thing, we'd go down, hit the TP, walk over the TP, and now we try to converge these points and try to meet them together. So this is how they should look like. Now in a normal spine where the exiting nerve root of that particular level would travel something like this, it will just swirl around the pedicle and go laterally. But the presence of a disc herniation over here is already pushing the exiting nerve root of that particular level slightly laterally and posteriorly. So the diagonal part of the Cambin's triangle is already extended, increasing the safety margin, increasing the dimensions of the Cambin's triangle so that you can directly go into the Cambin's triangle and do your procedure. So I feel that rather than triangulating over the pars, triangulating over the base of SAP is slightly more safer, especially when you are doing it under general anesthesia. But make sure that in lateral view you are at this level. You don't want to be too much anterior, because unlike in a normal interlaminar approach where there is a tough ligamentum flavum which is going to resist the entry of your blunt obturator inside, here we have an intertransverse membrane, but it's not that tough so that it can resist the force of a blunt obturator. If you push it slightly, it can cause unnecessary bleeding, maybe go into the retroperitoneal space. So you want to stick as close to the bone as possible, and once you go inside, once you visualize it under endoscope, then you should start exposing the intertransverse membrane. So this is a case of 53-year-old male patient with an L4-5 extraforaminal disc causing a severe left-sided radicular symptoms. That is the disc, so it is covering most of the foraminal and extraforaminal part. This is how it looked in the sagittal cuts in the foraminal sections. You can see it's a big chunk of disc there. This is the video. So this is the left side, that is right side. This is a facetal artery here. You have identified that. This is medial side, lateral side of the facet, and these are the intertransverse area. So the cranial TP will be here, caudal TP will be here. So our first aim is to identify the caudal TP. So you just use your RF tip probe to keep on getting the tactile feedback from the bone, and you have to identify the caudal TP first. Once you identify that, now you know in this plane you can travel safely from cranial to caudal direction without having the worry of going too much anteriorly. So the TP is going to guide you how much dorsal you need to go. Once you have done that, you go up and identify the foraminal ligament and the intertransverse ligament. That's the Cambin's safe part. So you confirm it on the CM that you are at the near the base of the SAP on the lateral part of the facet, and you start removing only that overhanging part of the bone which is covering the Camben's triangle. Once you get it into a single plane, and this is the exposure of the Camben's triangle. Now luckily for us, the exiting nerve root is already pushed laterally by a disc fragment, but we can still have a scopic retractor which can still protect the exiting nerve root when you are maneuvering your instruments inside. So this scopic retractor comes along with the scope, and you use it as a retractor to protect the exiting nerve root, which is not yet seen in the picture. You directly go from base of the Camben's triangle to the pathology. You identify the disc, you use the blunt tip obturator to poke your entry, or you can use a sharp annular cutter or an Indian knife to gain access to the disc base, and you start removing the disc fragments one by one. So this is the lateral border of SAP, this is the lower TP here. Exiting nerve root will be somewhere in this area, and you just go on removing the disc fragments one by one. In this case, because it is a foraminal disc as well, we need to go more centrally. So here I can put the disc punch and I can see where we are. So we are exactly at the lateral border of the lower pedicle. So we are yet to go towards the central portion. There is still some portion which is remaining. So we need to probe the axillary portion of the exiting nerve root and to see if there are any loose fragments which are coming out. And this way you can just keep on removing the fragments one by one. From this point onwards, we need to be more careful, because now the exiting nerve root is going to fall back into its normal position. Till this time it was pushed laterally and it was safe. So I prefer using a hook probe of the RF to gently dissect the foraminal ligament or the intertransverse membrane layer by layer till you start see fat and the foraminal vessel that accompanies the axillary portion of the exiting nerve root. And layer by layer dissection will slowly take you towards the exiting nerve root. This is your exiting nerve root here. Once you identify that, you know that this is the axillary portion. So this is the area that you want to decompress more. So this is the exiting nerve root exposed. Again, you use a ball tip probe. You go more towards the cranial pedicle and towards the medial side. And you can remove if there is any more fragment which is remaining in that particular area. I myself was a big fan of uniportal endoscopy till quite recently, but the kind of things that I'm able to do with UBE now is pushing me more and more away from uniportal. This is the axillary area. You can put the probe, you can actually take a C-arm shoot here to make sure that you can actually feel the caudal part of the cranial pedicle. Now we come to the foraminal part, and you just by tilt of your hand you can go as centrally as you want, and you can remove the fragment that is lying under the facet there. So the foraminal fragment you can remove very easily. If need be, you can still undercut the SAP if you want to visualize the lateral border of the traversing nerve root, if both the nerve roots are at stake and you feel that it is a necessary thing to do. Now this is cutting up the foraminal ligament which forms the roof of the exiting nerve root, starting from the tip of SAP going up to the cranial pedicle medial border. And you can de-roof the exiting nerve root and the complete nerve root, and you can practically looking at the Camben's triangle now and a free exiting nerve root there. So this is the disc fragment that was removed, and the patient was extremely happy. This is a slightly odd indication, I can say, where you have an upper lumbar level, I think 1-2 up migrated disc, which is almost lying at the medial border of the cranial pedicle. So I am not sure whether this disc is pushing the nerve root laterally or it's between the pedicle and the nerve root, pushing the nerve root more towards the intertransverse area. So I had consulted it with multiple of my Korean teachers that how should I approach this. And the majority opinion was you should do a paraspinal approach for this one as well. So this is one more small video. Here you can see the disc is not in the axillary portion here. The disc is lying underneath the nerve root and it is in between the cranial pedicle and the exiting nerve root. So I had first burred out the SAP. This is a right side. So this is cranial, this is caudal, that's medial, this is lateral. We have exposed this is the tip of SAP, this is foraminal ligament, this is the exiting nerve root that is coming out. We have exposed the exiting nerve root. Now I am cutting through the foraminal ligament. Luckily for us at the upper lumbar levels, because the facets are very vertically oriented, without cutting too much of the facet, you can actually go and see the lateral border of the thecal sac. So by cutting down onto this part, you will be able to see that there is a pulsating fat coming there. And once you remove this portion of the foraminal ligament, you should be able to see the lateral border of the thecal sac right there. So this is the exiting nerve root. Some part of the disc is now seen in this area, here, the axillary portion. And the thecal sac will be seen. Now we can see that the fat is pulsating there. So these angled curettes are very useful in this particular area. And after removing a sufficient portion of the foraminal ligament there and some portion of the lateral extension of ligamentum flavum, we are able to expose the lateral border of the thecal sac. So this is the thecal sac here. Still some fat on top of it. And this is the lateral border of the thecal sac. So that's the thecal sac. This is the exiting nerve root. Now we know the disc is going up from here. So you start probing the disc with a blunt tip probe and get the tail into the operating field and then take it out in a piecemeal manner. So without any neural tissue retraction, without having to worry that it's an upper lumbar level L1, 2 and retracting the, you don't want to manipulate the dura too much at that level. So these are the fragments that are coming out quite easily. Even after doing this, I could see that there is some fragment here, but I am not able to reach up to that particular fragment. So I tried lifting the nerve root up. I can see that there's still some fragment here which is quite high up, moving quite up. So I started taking some bites of the caudal end of the cranial transverse process so that I can go between the pedicle and the exiting nerve root. So this is the caudal TP and some overhanging portion of the intertransverse ligament. You start taking bites, you free the shoulder area of the exiting nerve root, and then you try to push the exiting nerve root downwards so that between the cranial pedicle, so this is a scopic sleeve. I try to introduce the scopic sleeve which I can rotate later on, the same way we would do in a uniportal endoscopy using the bevel of the channel of the scope to retract the nerve root and making space onto the shoulder area of the exiting nerve root. And once you do that, you will see that there is a disc fragment which is lying here between the cranial pedicle and the nerve root. You can probe that fragment out easily, and that last piece of disc which is lying between the pedicle and the exiting nerve root. And now you'll be able to see that the exiting nerve root is completely free with both the shoulder area and the axillary portion being decompressed very well. This is the postoperative MRI of the same patient, wherein you can see that the disc fragment which was there preoperatively, it is gone. There's still some annular shadow which is there. And in this area, you should be able to see where the foraminal ligament is actually cut in the postoperative part here. The foraminal ligament is actually cut there and the foramen is widened sufficiently. So that's about it. One more good indication for this technique is when open decompression surgery is done previously and you have a disc herniation again and you don't want to go through that scar tissue. Again, this has become one of my favorite go-to techniques. Thank you. Any questions? Yeah.
Wonderful videos.
Open to question and
Any questions from Dr. Ketan?
From the house wants to ask him anything?
I would
Dr. Ketan,
request.
what is your observation of dysesthetic pain, especially when you're opening around the DRG in such cases, as compared to the other techniques which you have done in the past?
Except for that one case, otherwise I don't go and manipulate too much into that area. Even if you just remove the disc and not expose the exiting nerve root this much, this was just for demonstration. I would not do it in all the cases. That particular case, I was also worried because DRG was right there and the fragment was gone quite high up. So I had put in some DEXA. I had to use some pregabalin in that case. There was some dysesthesia to that particular patient. Otherwise, for an extraforaminal disc, I will not do too much of exiting nerve root probing and this thing. Only I'll just go remove the fragment. It is just to show you the versatility that if need be, you can do this also.
You have a very pertinent question. Ketan, fantastic talk. If you were to compare transforaminal with UB or with even monoportal in decompression of the foramen, please understand one thing. You are putting in a 7-8 millimeter dilator sheath and then doing your work in the Camben's triangle. Now this, when you're doing that work for 20 minutes or more, you are causing constant compression like a ligature on the nerve root. Therefore, root dysesthesia in transforaminal surgeries, especially with junior surgeons, is almost 20 to 25%. I will not say that about Dr. Bhanot because he's an excellent transforaminal surgeon. He'll finish his job like this and walk out. He will not enter a tight foramen, he will go outside in. But we talk about standard inside-out procedure. Standard is what the student would learn. So he will have a very high incidence of root dysesthesia. Now the difference between UB and monoportal is that we are not touching the root. We are hardly handling it. We are just decompressing it from all around it. So therefore, whether I do it for 2 hours or whether I do it for 1 hour or whether I do it in my learning curve and come down to 30 minutes, the incidence of root dysesthesia, unless you genuinely manipulated the root badly or hit it badly with your wand, will not happen. These patients will do excellently well. So monoportal as well as biportal have this distinct advantage over transforaminal. So that was the relevance of your question, sir. Thank you. It was a very intelligent question. Thank you, Ketan.
Thank you both, Dr. Malcolm and Dr. Ketan, for those wonderful presentations and inputs.
I would request Dr. Anu Joshi to please present our speaker with a token of gratitude. I would like to introduce and call on stage our eminent faculty to chair our next session. I would introduce and welcome Dr. Arun Bhanot, a leading orthopedic spine surgeon, to grace our conference. Please join us on the dais, sir. Dr. Shashav Shah, an esteemed spine surgeon and a specialist in endoscopic procedures. Sir, please grace us with your presence. Dr. Ashish Tomar, senior consultant in orthopedics and spine surgery. I request sir to join us on the chair. I would like to introduce our first speaker, Dr. Anandya Basu. He's a highly experienced orthopedic surgeon specializing in spine surgery and has extensive training in India and UK and focuses on minimally invasive procedures, cervical spine, scoliosis correction. His talk is about UVE TLIF. Thank you.
A big thanks to Professor Kaul and Professor Kashyap for the kind invitation. I'm very happy to be here in Sharda University. Fantastic campus, wonderful audiovisual arrangements for this lecture. Right. So lumbar fusion for, done by UV technique is something which we started doing about I would say 1.5 years back. And I've done quite a few cases now. Let's see what my experience and journey of UB TLIF is. So what I would say is that the indications are similar to MIS TLIF. I haven't done very high-grade case with very high-grade lysis with UB, but I've done up to grade 2, grade 3, which can be reduced up to grade 2. Those cases I've done, but obviously spondyloptosis or very high-grade lysis, dysplastic ones, I haven't done. And obviously recurrent disc herniation, central foraminal stenosis with instability. These are the standard indications for any lumbar stabilization. You can do it MIS, you can do it with tubular, you can do it open, and UV TLIF can also be done in all these cases. So I'll show a small video, and it's very important, to identify first that you have to land in the sound space. The sound space is actually a potential space medial to the multifidus muscle. So the idea of UB is you are trying to preserve the multifidus muscle. You're trying to go into the potential space which is under the multifidus muscle and the lamina. So basically, the potential space, normally when we do a tubular surgery, we do remove a bit of muscle over the lamina to reach the bone. Here, what we do is we lift or we retract the multifidus muscle, and we reach the lamina. And in the sound space, which is actually a potential space, is what actually lies is loose areolar tissue, and we are lifting that space up. We are creating the space with water, with fluid, and we are starting our surgery. So in that way, it is more minimally invasive than any other minimal invasive procedures, UB. So that is a very important strategy. If you see in this, when I went inside, the first thing I saw is bone. I'm not removing any muscle with my RF. So I'm landing on the sound space. You can see this that I've landed on the bone. And after you have put in your scope, after you have landed, if you see a lot of muscle, that means your landing is not good. You have not landed in the proper space. And if you have to burn a lot of muscle with your probe, that means you have not landed properly in the sound space. So you don't have to detach any muscle of the lamina because there is no attachment over it. It is actually a potential space in which lies loose areolar tissue. If you look at this image, it's a very, very important image. Is there a pointer here? I don't know. So if you look at this space, this is actually a potential space. We are filling this space up with water, lifting the multifidus up, and this is the space that we need to land into. There is no muscle attachment in that space. So that is the most important thing, I think. So, rest of the surgery is same. We have all done spine surgeries. But if you are landing properly, and after landing, if you see the lamina, and if you are in the sound space, that means 80% of your job is done. So, when I visited Professor Sun, every morning for 3 weeks, he was presenting this image. Every morning, he used to spend 5 to 10 minutes with this image. And he hammered this image so much into our mind that I try to, hammer it into people's mind when I go there. So regarding operative technique, we all know, we've seen, how to dock. I dock grossly for TLIF. I dock, at the level of the pedicles, and for the lower port, I dock over just close to the disc space, because otherwise you'll have a steep landing, steep angle for putting in the cage. So let's go into the video. This is after landing into the sound space. Once you have landed in the sound space, you don't have to use the RF much to burn any muscle. You can straight away identify the spinolaminar junction and start drilling. You start drilling, you go up to the, you drill the bone, reach up to the upper level of attachment of the ligamentum flavum. And, this video was shot, quite a few months back. What I try to do now is use the drill as less as possible and use Kerrison mode so that I can have more bone for bone grafting. So you're drilling away basically the base of the spinous process, trying to go to the opposite side. You have preserved the ligamentum flavum, and I try to take out the ligamentum flavum in toto. I do a lot of tubular MIS TLIF as well. In that surgery also, I try to take the ligamentum flavum in toto, because that, that reduces the surgical time and obviously, and sometimes. And but in UB, taking out the ligamentum flavum in toto is a bit of tedious task compared to tubular surgery, I would feel. But then if you can take it out in toto, I think the chances of dural injury are much less, because you are detaching the ligamentum flavum from all its attachments, and you're taking it out, so the number of kerison punch bites that you need to make is less, and your chances of damaging the dura is less as well. So here what I'm doing is I'm taking out the IAP using the osteotome to over the parts, and taking out the IAP and to access this space. Sometimes if you have a big IAP, if you have a big facet joint, you can break it into smaller pieces using the osteotome and take out small chunks, because like tube, even if in tube you can take out the big IAP as a whole, but in endoscopy through the portals, if you try to take out a big IAP, you'll struggle and you can cause more damage to the muscles. So if there is a big IAP, what you can do is you can break it into small pieces using osteotome and take out piecemeal. Sorry, there was a technical glitch. So you've taken out the SAP, IAP, you've taken out the upper part of the SAP, and you're approaching the disc space through the foramen. You can use the standard shavers initially, and then under vision you can actually prepare the end plates. The advantage of of UB over tubular surgery is that you can actually prepare the end plates under direct vision. You can use these cuvettes, you can see the end plates, you can see the adequacy of preparation, you can see the bleeding endpoints. The chances of damaging the end plates is much less in UB compared to tubular TLIF. And after that, you can put in the bone graft using funnel, and after that you can directly put in the cage. I now put in the cage. In this case, I put in the cage under radiologic guidance, but I now put in the cage under direct vision, and then check with radiology. You can see that opposite side complete decompression has been done. The opposite sided traversing root is mobile. You have done a complete lateral recess decompression on the opposite side, and you can see the cage placement on the ipsilateral side as well. This is a short video on en-bloc flavectomy. If you're planning to do an en-bloc flavectomy, what you have to do is you have to lift up the flavum from the caudal lamina, a superficial layer of the flavum from the caudal lamina. Take a few bites on the caudal lamina, and then you can take out the flavum in toto. So here you can see that how the superficial layer of the flavum has been taken off. Then you take a few bites, detach the flavum of the caudal lamina. Here you can see actually, the flavum is retracted after taking a few bites. deformed butterfly, I would say. No, this is a short video of the end plate preparation. This is the insight of, how you can see actually the amount of bleeding bone, the amount, you can see the ALL, you can see as, as deep as the ALL, you can do the end plate preparation, take out more disc, as much disc as you want. If you compare this view to, microscopic view, because I do a lot of microscopic like TLIF as well, tubular TLIF. If you compare this view to the microscopic view, there's a lot of difference. Here you can actually see the end plates. You can see the ALL. You can see the amount of the end plates that you need to prepare. You can see the amount of discs that you have taken out, the amount of discs remaining. So the end plate preparation is much better and much meticulous in UB compared to other forms. My mentors are also here, Dr. Malcolm Bestanji, Dr. Ketan Deshpande. And I would, I'm a bit nervous because I'm showing off my video in front of them. I would encourage them to criticize me after this talk. So you see the meticulousness of end plate preparation. This is a specialty of UB surgery. I think this meticulousness is not possible in any other form. In the visuals, you can actually go inside. Some people, I'm using a 0-degree scope here, but some people use for this step, use a 30-degree scope and go inside the disc space, and they can have a panoramic view of inside, inside the disc space, the amount of bone that they've prepared. You can actually see the bleeding endpoints. You can go down deep up to the ALL, and safely under direct vision you're taking the discs out. There's you're not afraid of going through the ALL or damaging the anterior structures. So the glistening structure in front, through the disc, you can see the ALL. So this is the view that you get in microscope. Compare that, the last view that you saw, compare this to a microscope. This is the same surgery I'm doing under microscope. And this is a good microscope. This is a Pentero microscope with good magnification. But still, you see, this is the view that you get from microscope, even if you work under high magnification. And this is more of a blind procedure under microscope as well, that is end plate preparation. But if you compare this to the UB, it is basically a direct, the end plate preparation is under direct vision. And you will be amazed to see the amount of bone graft, amount of fusion mass forming in these patients if you do a meticulous end plate preparation after 3 months. These standard Medtronic instruments I'm using for preparing the end plates, and you can see that this is a blind. Basically, you are more relying on your tactile feedback for preparing the end plates under microscope. Here you can see another thing is that under microscope you're working with always with a bent back, or you're glued to the eyepiece. Here the ergonomics of the surgeon in UB is also very, very comfortable. You're standing, your screen is at the level of your eyes. You're looking at the thing, and with so much of ease you can palpate the opposite side, lateral recess, ipsilateral lateral recess. It's ergonomically, even if it is more time consuming, it is more ergonomic for the surgeon, UB surgery. That is what I feel. Now, obviously, at the end of the surgery, it's very important to check hemostasis, because epidural hematoma can give rise to a lot of back pain and neurological compromise. So what I do is I just stop the flow of water and check if there is any bleeding points, and then I can restart the water. So meticulous hemostasis is very important at the end of the surgery before you call it a day. And if you're satisfied, just sometimes, you know, I do put in a drain if I feel that there is, I put in a drain through the same hole, through the working portal, under direct vision into the epidural space. If I'm not satisfied with the hemostasis or I feel that I need to put in a drain, I do that. I do use expandable cages. I've used quite a few cases, but then I stopped using them because it causes a lot of end plate damage. That's what I feel. This is a kind of grade 2 lysis done with UB. So obviously these are the advantages of which I feel the vision is great, and end plate preparation, the meticulousness is significant compared to other techniques. And obviously these are some of the limitations. And if you do have a dural tear, if it's a big one, you have to convert it to a microsurgery. That's what I have done. But you know, advanced, you know, more experienced surgeons can repair the dura under endoscope as well. Thanks. These all my mentors. I missed out Dr. Ketan's photo here. Dr. Pestanji is here in one of the photos. I visited him for a course, and thank you for the attention.
Thank you, Dr. Anand. Very wonderful presentation. Any questions to Dr. Basu from the house? Yes, there's one from the house first.
I'd like to ask. I'd like to ask one question.
Sure.
What do you do for right-sided pathologies? A very nice video presentation, by the way.
So right-sided pathologies, if if I'm doing a T-leaf.
T-leaf, yes.
Yeah.
T-leaf. I mean, we are trained like if I want to insert a cage, then I decide which side is the more pathological
If I'm doing it for a stenosis, and more or less both the sides have equal, the complaints are grossly equal on both sides. And even if its light is a bit more, if I'm doing for stenosis, I do it through the left side.
I'm talking only if the pain is only on the right.
If I want to do it for a disc pathology, where I'm operating from the right side, then I do operate from the right side, standing on the right side of the patient.
No. I'm talking about a T-leaf. If there is a listhesis and the patient is having more pain on the right side.
Right.
You want to insert a cage.
From the right side.
You insert a cage from the right side only. Okay.
But if I'm operating for a stenosis with claudication, even if the pain symptoms are more on the right side, I'm quite confident of decompressing both the traversing routes from the left side. I do it from the left side because the workflow is better.
So you are comfortable inserting the cage on the right side, right?
Yeah.
Seshav, I have a question for you. You're married? You're married? Yes or no? बीवी को बोला मैं राइट हैंड सर्जन हूँ? नहीं ना? राइट लेफ्ट दोनों सीखो यार. Simple thing. Little slow, it takes a little time, but it's all doable. We have that, mental, I don't know, many of you are not neurosurgeons here, but if you're neurosurgeons, you'd be doing endonasal with both hands. So why the hell you can't do here? Just 5 minutes ज़्यादा लगेगा यार, left hand से करने में. थोड़ा slow होगा, थोड़ा initial shake होगा, and then as the numbers go up, it just comes. So eventually being stuck with hand domination is not the concept.
So like what the only advantage I would think is the end plate preparation is a hugely different thing compared in UV compared to other things. We can. Yeah. And again, the amount of muscle damage in UV is much less compared to tube. These are the two things I think different in UV.
Just one question. Great presentation, Dr. Basu, from here. So, initially when we start out doing T-lifts, so how long would be the duration of surgery, and how would we take care of the water pressure if the time
water, that is a very important thing. My surgical time is about 2 hours for T-leaf. When I started, it was the first case, couple of cases, 3.5 hours it went. And now with time my surgery is, but I'm struggling to get it below 2 hours. I don't think it's like I'll be able to do it in but with tubular TLIF, I'm very fast. I can do it in 1 hour, 15 minutes, 1 hour sometimes. So, but UV TLIF, I'm struggling to get it below 2 hours.
If I'll just cut in, what he actually did, and he did not even stress on it, he did a very beautiful thing. I don't know how many of you will appreciated that video. He did not initially remove the flavum. You do the decompression. You do all the bony work. You remove the IAP, remove the SAP. Don't remove the flavum. Use whatever water pressure you want. Your dura is protected. The nerve root is very, very resistant to water pressure. Do your TLIF. If you see any of my YouTube videos on TLIF, it's crystal clear imagination, vision. Crystal clear, not a drop of blood. Because after I put in the graft, which I normally harvest from the anterior iliac crest, I'll be very honest, I don't use facetal bone. Sclerotic bone, I don't depend on it. Because the end goal of any surgery is fusion. You do a very beautiful TLIF and it doesn't fuse, bad work. So I use anterior iliac crest graft harvested at the beginning of the surgery. Like he showed, I put in the graft through the tube. I put in the cage. Now when I put in the cage and the cage causes expansion, the flavum auto separates. So after putting in the cage, making sure everything is fine, putting a small tab of gel foam over there, then I start the flavectomy. Flavectomy is the last 8 minutes of the whole TLIF surgery. Now what effect water pressure has? 0. Watch the video on YouTube, son. You don't need to. Sir, if your cage is adequate size, मैं सच बोलता हूँ, supposing आपका 8 mm का डिस्क स्पेस है, आपने उसको वहाँ 14 mm का केज डाल दिया, right? 7 mm से तो आपका फ्लेवम रिट्रैक्ट हो गया ना, आपने बाकी का तो फिक्स कर दिया, काय को फ्लेवेक्टमी भी करनी है, कोई ज़रूरी नहीं है सर. It's only when it's a shiasis grade C, grade D, ड्यूरा नहीं दिख रहा है प्री-ऑपरेटिवली, चलो हम सोचते हैं यार काय को रिस्क लेना पूरा कर दे काम, नहीं तो कोई ज़रूरत नहीं है सर.
I would disagree with that point. I feel that when you try to put a cage which is adequately sized and you want to distract those end plates, the contralateral lateral recess, we are forgetting about that. If you distract, the flava is going to push down onto the traversing nerve root with a deformed facet already on the opposite side, which you have not removed. I, before putting in the cage, would like to see the lateral border of the traversing nerve root on the opposite side. If there is any SAP hypertrophy on that part, I would like to cut it. I would like to visually see 2 to 3 mm of space lateral to the lateral border of the traversing nerve root before I put my cage. One of my patients had dysesthesia of the opposite side. He was symptomatic on the left side. I did the same thing. Only ipsilateral flavectomy, put in the cage. The patient had right-sided pain later on. So now what I do is, it's a very simple job of going to the opposite side and removing that flavor, even easier than ipsilateral.
I think I should agree with both of you in a way. When you have scissors C and D, then you will do what you said. Yeah. You will remove the flavectomy. But when you are doing a grade 1 listhesis or only lateral stenosis or something like that, then I would not do a flavectomy. And Aditya, who assists me in Bhubaneswar, keeps saying that the Koreans and Ketan and Malcolm G do a complete flavectomy. So I do all my MIS TLIFs through the SAP process without doing a flavectomy. So I agree with scissors C and D, you would do a flavectomy.
And I agree with that. I mean, if I'm doing for instability, mainly for an instability, and with the unilateral symptoms, I do just take out the facet, do the exiting and traversing nerve root decompression on that side, and put in a big size cage. That's it.
So Ananda, wonderful visualization of the end plates, and that is one of the one big advantage of endo TLIF which you proposed. So I'm not critically asking this question, but I just want to know what the literature, how much does it support? Does the endo TLIF has a better fusion rate at the end of it as compared to an MIS TLIF?
There is no RCT available till now, quality RCT. I mean, there are 3-4 registered studies which are going on, which will give us the answer to these questions. As of now, there is no RCT or level 1 study to support.
And in your, Dr. Ketan's, Dr. Malcolm's experience, does endo TLIF give better fusion rates?
Fusion rates are excellent. I don't doubt in that.
No, as compared to an MIS standard MIS
Absolutely,
TLIF.
absolutely. I don't doubt that. The fusion rates are excellent.
The endo TLIF has a better fusion rate.
Fusion rates are the same. I mean,
so they are essentially
better. I cannot say better.
but the fusion rates are the same.
So there are two issues here. One is end plate preparation. We definitely do a much better end plate preparation because it's visualized. There's no cartilage left behind. You see, when you use the rotary shavers, sometimes you are not sure whether you have actually properly shaved that much amount of end plate. Either you will aggressively cut into the end plate and destroy the end plate in an osteoporotic bone, or if it is a hard bone, you may just leave behind cartilage and you will have poor fusion rates in regular TLF surgeries. In endo TLF, whether it is severe osteoporosis, I can still with a curette gently remove the cartilage, keeping as much of subcortical bone as I wish to. And I can prepare a vast bed. Like he mentioned, you can go right till the ALL. You can pack in max amount of graft, much more than you can even imagine. Means 2-3 tube भर के graft डाल सकते हो आप. Literally 3 such tubes of graft you can pack in. Now things have changed. We are using larger, I use what is now called as a multi-lift T-leg cage, which is like an olive cage, but with a banana cage handle behind. So we introduce 40-45 mm big cages, place them horizontally. Therefore, we don't have cage subsidence issues. Maximum amount of graft being packed in, better end plate preparation. Now the argument is that the fluid washes away the bone marrow. So, but ideally what? That fluid putting in the graft and then putting in the cage behind, that is a matter of not even a few minutes.
No,
so there's really not much washing of the graft occurring over
it
there.
It does not get washed away. So one small thing I do is when I'm putting in, through the funnel I'm putting in the graft, I use a small, very thin film of bone wax below, to seal, because when I'm getting it into the disc space, I seal the the bottom of the funnel with a very thin film of bone wax, and I can get it into the disc space and hammer it in. And after that, fluid washing away the bone graft I have not seen.
One more thing for that, it says the work that we do in an open surgery which is blind, I did in one day I did 2 cases. First was an MIS TLIF, then an endoscopic TLIF. So first in MIS TLIF, the shaver work inside the disc work that we do, the same amount of work I first did in my endo TLIF, and then I went in. When I went in, after that I had to do almost 20 minutes of job for the end plates. So this is the difference what I personally believe, that in an endoscopic TLIF, we generally tend to do more of the end plate preparation when compared to an open surgery. I would not say that in that case my patient did not get fused, but the end plate preparation which is more important than even I guess the bone graft. If the end plates are properly prepared, then I think the fusion rates are good.
Tarun, when we do MIS TLIF or let's say open TLIF also, we use the shavers blindly in the central concave part of the disc many times, because when we do endo TLIF, when we introduce, like I do uniportal endo TLIF, so early part of my disc preparation is done fluoroscopically and then I switch over to endoscope. So sometimes after doing that fluoroscopically, when I put the endoscope, you still see a central concave area which is still having the cartilage over there. So that way endo TLIF does add an advantage in visually removing all the cartilage that you want to do. And as Dr. Malcolm said, that part you can do very gently without destroying the osteoporotic bone. So that has a superior advantage when you talk of endo TLIF in terms of end plate preparation under direct vision.
And it takes more time also. And my UB TLIF end plate preparation takes about 20-25 minutes, and my MIS TLIF end plate preparation takes 5 minutes, 7 minutes maybe.
Dr. Basu, I have a small comment on what you said in the beginning, that when you introduce your scopes, you directly land on the son space and you don't have to strip any muscle.
Yeah.
But you showed in your own video, fluoroscopically you've already done a lot of stripping.
That was a demonstration video. I mean, I understand that that was basically, I did a stripping, little bit of stripping that, but that stripping actually I don't do. That was shot quite some time back. Now I just dilate the thing, and if I just go place the dock at the right place, use the dilators, and then go straight away with the thing. You don't need to do a lot of this muscle detacher. I don't use at all. That muscle detacher.
That is great, but I think most of us who are doing it, tend to strip.
Now, what you need to do is basically you need to strip the bands, the tissue bands, to completely create the sound space. The sound space is actually, it is a longitudinal space, and the space is already there. And by doing this movement, actually I'm not stripping any muscle. I have landed medial to the multifidus, and then I'm just detaching all soft tissue bands along that space. And then when the fluid goes in, what it does is lifts up the multifidus muscle. And then you can, this is a little bit of difficult step, I would say, because, once you're working in a potential space, so the muscle is trying to collapse on your vision. And once the moment you start drilling the bone, the space becomes an actual space. And if you have drilled even a little bit of bone, that trough is created, your life becomes easier. From there, you can carry on very easily. So what I try to do is I try to go there, identify the bone, identify the spinolaminar junction, and start drilling as early as possible. And even if I drill a little bit of bone, the trough is created, and then the vision and optics and handling and triangulation, everything becomes easy.
So if there are no more questions, can we move on to the second talk?
Sir, I would like Dr. Albert D'Souza from our hospital itself to present our speaker with a memento of our appreciation. Request the IT team to prepare for the next session.
We will now have a session with Dr. Chung from he's a neurosurgeon based in Seoul, South Korea, with 20 plus years experience in the field. He specializes in cervical disorders, spinal tumors, minimally invasive spine surgery, cerebral aneurysms, and cerebrovascular malformations. His talk is on how to avoid complications during UBE surgery. I would request the IT team to please proceed ahead with this.
Good afternoon, everyone. I'm Professor Jung Gi-jo at the Catholic University of Korea here in Seoul, Korea. Thanks for inviting me. Today, my topic is how to avoid complications during UBE surgery. This presentation is from my 6+ years of experience of UBE surgery. This lecture is not for the expert and masters of UBE, but for the spine surgeons just started or about to start UBE. And this is confined to lumbar UBE surgery, not including cervical and thoracic surgeries. This is the most painful complication of UBE surgery ever have experienced. He had L4-5 stable degenerative spondylolisthesis, and during surgery, I made a large dural tear, and I treated him with Kosel packing and finished the surgery. However, he developed cauda equina syndrome one day after surgery. So I did emergent subtotal laminectomy, and you can see the large dura defect and Kosel in the dura. I did primary closure with sutures, but unfortunately, he had permanent urologic deficit. From this experience, I learned a painful but valuable lesson. From my experience, transition from conventional to endoscopic spine surgery was not easy. As we all know, complications of minimally invasive spine surgery are not always minimal. UB surgery can cause catastrophic complications. In this patient, he had paraparesis after C7T1 UB posterior cervical discectomy. Like other surgeries, UB also requires a learning curve. Most authors suggested that 50 cases are enough for master UB, but I don't think so. My data is very honest and realistic, and it is much higher than others. And these data including asymptomatic complications. From my experience, most common complication was dural tear. 3 cases were converted to open surgery during surgery. 3 cases needed later open repair surgery. Next common complication was post-op epidural hematoma. 7 patients required revision surgery, and there were few incomplete decompression and wrong-level surgeries, all in the early stage. I have one permanent urology deficit. I already mentioned about this patient. I guess too much Kosel caused mass effect and nerve damage in this patient. I should treat large dural tear, not by Kosel, but by direct repair. And you should be very careful about using RF coagulation to prevent thermal nerve damage. As you can see, complications dramatically decreased from 2023. At this point, I also felt truly comfortable and proficient with the surgery. Revision rate also decreased with experience. So you need more than 50 cases to master UB surgery. And I always consider misdiagnosis and poor surgical planning before operation as a complication. This patient had protruded disc, severe central and foraminal stenosis, not a good candidate for UB decompression. However, he strongly desired the UB surgery. So I did the UB decompression, but his symptoms were worsened after surgery. I did MIS TLIP in this patient. Fortunately, his symptoms improved after second operation. UB decompression is not almighty. Sometimes you should choose other than UB even when patient strongly desire UB surgery. Bleeding always makes surgeon angry, frustrated, and exhausted during surgery. This is especially true in endoscopic spine surgery because we cannot see anything, even with a small amount of bleeding. So every effort should be made to stop bleeding during UB surgery. And blood pressure is closely related with bleeding, so you better keep systolic blood pressure under 100 mm mercury during surgery. This patient had severe bleeding during surgery and had a symptomatic epidural hematoma after surgery. She was very old and had been taking aspirin before surgery. Old age and aspirin are common causes of bleeding during and after surgery. Also, bleeding is a usual cause of incomplete decompression like this patient. For me, dural tear is the most common and most feared complication. I'm currently gathering all the data on patients with dural tear and analyzing data to write a paper about dural tear. Small dural tear less than 5 mm can be treated with Kosel patching. First, you must seal the defect with Kosel to prevent CS leak and nerve root herniation after surgery. And then cover the defect with Kosel for further sealing of dural tear. In some cases, like this patient, direct repair of dural tear is possible with brecciate clips, but this is not always possible. And when you are doing clipping, you must make sure that clip full thickness and full length of dural tear. This video typically shows how dural tear occurs during UB surgery. Insufficient laminotomy using kerosene punch in the tight space under the ligament flavum and blind use of sharp instrument. You can see large dural defect that cannot be treated with brecciate grip under endoscopic view. So I converted to open surgery and treated with brecciate clip and Kosel patch. In my opinion, dural tear is not a minor asymptomatic complication. Dural tear is a common cause of post-operative epidural hematoma because we cannot use suction drainage properly after surgery. And dural tear can cause arachnoiditis and epidural scarring because of bleeding. In this case, dural tear was treated with Kosel patch. However, patient had symptomatic epidural hematoma, which required revision surgery. So, how can you avoid complications during UB surgery? I strongly recommend the use of specially designed shaver drill for UB surgery. This drill is very powerful, does not cause turbulence, and remove debris during surgery with suction function, which provide clear operation field. Use this drill is awkward and difficult for beginners, but you should try this drill to reduce operation time and complete and sufficient bone removal is mandatory to reduce complication. You can see I'm doing sublaminar contralateral decompression with this shaver drill, and you can see how clear the operation field is. I usually drill off the bone from the ligament flavum to define the cranial and caudal end of ligament flavum. You can see the contralateral facet joint, and now I'm drilling inferior facet joint. And use micro drill. I detach ligament flavum from bone. Using this technique, reduce chance of dural tear, and this technique makes operation much easier and safer and minimize the requirement of calcium punch use. Calcium punch is always the usual cause of dural tear, and now I remove last piece of the ligamentum flavum, and then I remove the ligamentum flavum in one piece. Using this method, you can reduce complication like epidural bleeding and dural tear. Now I remove the ipsilateral ligamentum flavum. Ligamentum flavum is acting as a protector of the dural matter during surgery. Now you can see the final. These are my take-home messages. You should be prepared before you start, and precise and accurate diagnosis is mandatory for successful surgery. And sufficient but not excessive decompression is the key to successful and complication-free surgery. And lastly, know your limit, and please do what you can do. Thanks for your attention.
Dr. Chu, thank you so much for a very sincere presentation on the very dreaded issue of complications, especially when you have to present your own serious complications. Do we have any questions from audience for Dr. Chu?
Professor Dr. Shaishav this side. I would like to ask what is your protocol for your dural tears? I mean, does it depend on your size? And when do you leave it? When do you tacosel it? And when do you repair or clip it?
Your mic is mute. We can't hear you. Can the audiovisual team fix it? Dr. Chu, please wait. Please wait. We are just checking the audiovisual. Yeah, please, Dr. Chu, can you answer the question now?
Can you hear me?
Yes, now we can hear you. Thank you.
Okay, that's good. Good afternoon. First question, I heard about how I treat the dural tear depending on the size. That's correct?
Yes.
Yes. The most of UB surgeons in Korea recommending in the ranks, the less than 5 millimeter can be treated with tacosel patching only, and then between 5 to 10 millimeter depends on case, depends on the size and contour of dural tear. If you have clear contour and then the cut margin is clear, you can use clip, or you can even use tacosel when there is no dural defect, just slit like dural tear. But even if you have more than 10 millimeter in length or a large dural defect, you already remove some portion of the dural matter with the instrument. You better open it and primary close with suture or VCS by microscope.
I have a similar question on use of tacosel.
Yeah.
In the first case you showed, which developed cauda equina syndrome.
Yes.
Usually when we do endoscopies and there is a dural tear and you want to use tacosel, the challenge is that the pressure of the fluid tends to push back your tacosel, and that is why you tend to try to push it more, and that is the tacosel enters inside the defect. So how do you manage the fluid pressure to place it on the dural defect rather than through the defect?
Usually fluid pressure cannot prevent the herniation of the root through the dural defect when you make a large dural defect during surgery. So you need to make some buffer or a protector for preventing nerve root herniation through the dural defects. Some Korean surgeons use gel foam, large gel foam. Someone are using Kosel, but with that. After that complication, I usually open and convert to microscope when I make a large dural defect. So that case was so painful to me.
Okay, thank you. Any questions for Dr. Chu from the audience? Yes, one mic please over there. Dr. Chu, there is a question from audience that once you repair the dura, do you use a drain?
And keep it positive pressure, not negative.
Oh yeah. Dural defect. Usually, I use my protocol for after I'm making a dural tear. Usually, if I make a small dural tear, I always insert suction drainage and just half pressure, not full negative pressure, and use it 1 or 2 days, and then check the CSF leakage. If there's no CSF leakage, I remove it. But when you have some CSF leakage, sometimes I just remove drain to prevent further CSF leaks through the dural defect. And one day after removal of the drain, I always keep the patient bed rest 1 day and then check the wound if there's no CSF, and then I ambulate them. Okay.
Thank you.
Thank you.
Just one thing I want to clarify is that if you have a large dural defect, then you will have to convert the endoscopic to open microscopic to stitch. Otherwise, you can't stitch it through the tube, can you?
That is what you said.
It depends on the size and the location. When you make a dural defect, you can reach it through the small laminotomy. You can suture it directly. You don't need to make more bone removal. Sometimes you cannot reach it. So usually you better make a subtotal laminectomy and then suture it perfectly, and that's the minimize the complication and then improve outcome of the patient with dural tear.
Sir, if the defect is large and cannot be sealed with Kosel, but it can be used closed with clip, the dural clip, that can be introduced through the endoscope, yes. But if it is in an inaccessible area where you can't apply the clip or it is too big, then probably you have to convert. That's what he mentioned.
I would not shy off from opening up and repair it once it is, if the defect more than 5 mm, that as he said. And about drain, I would say the tissue pressure as such is quite big. We just dilate the tissues, so the positive pressure is always already there. So we not insert a drain on positive pressure.
I would request Dr. Rakesh Kumar from Sharda Hospital to please present our chairing dignitaries with a token of our appreciation, so we can proceed to lunch after this.
Thank you, Dr. Cho, for your wonderful presentation. We all appreciate it. Thank you.
Thank you. Thank you so much.
I would request everyone to please step out for lunch, following which, for the cadaveric workshop, there will be a bus to take you all there.